Good morning, everyone. So, today is the fourth day of our Gyan workshop. So, to continue our first session, I would like to request Professor Kavita Shah ma'am to be in the stage, deliver our first link. Thank you, ma'am.
Why did I only cover until 11? It makes no sense. First day were 3 lectures only. Oh, that's why. Because I was thinking, okay, what has happened to me that I'm even calculating the. Okay, that's how. Because I thought 11, 3 lectures yesterday. Okay, so so today we start with pharmacogenomics. Okay, this is a new word. So pharmacogenomics is abbreviated by PGX. Okay, and this is a very important concept. Okay, so 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 when you talk about pharmacology, we all know pharmacology. Okay, so pharmacology has many components within it. So one is pharmacodynamics, which we briefly saw yesterday, and we are going to see it more today. So pharmacodynamics in very simple words is what does the drug do to our body. That means if you take a drug, where is it going, where is it binding, what it is doing, is it reducing the disease, right? So it is mechanism of action, drug receptor interaction. What is a drug actually doing in our body? Pharmacokinetics is what the body is doing to the drug. Okay, so that means, have you guys heard of ADME, right? So, oh, you guys are pharmaceutical students. Many of you are, right? You are. So, yeah, of course, you know this thing very well. And this is pharmacogenomics. So, this is a very different concept. And we will focus on this today. And toxicology, you know, right? For every drug, we have to do toxicology studies to see whether it is toxic or not. And then finally, it is clinical pharmacology. So let's see what is PGX. So when you look PGX in literature, it is very confusing because people do not understand the actual meaning of PGX. So they have included many things. So I'm going to tell you exactly what is classical PGX. Okay. So PGX, this pharmacogenomics is made of two words, pharmacology and genomics. You combine. So anytime you have the omic word in the end, what does it tell you? If it is genomics versus genetics, right? If it is proteomics or omic, any omic, what does it tell you? Metabolomic, what does omic tell you? What is the meaning of omic? It is global. You're looking across the whole thing. If you're working with a cell line, you're looking at all the proteins in the cell line. If you're working with the organism, everything within that organism, right? So it is genomics and pharmacology, which together makes pharmacogenomics. Now pay attention to this word. PGX is the field that studies how a person's genetic makeup affects their response to medication. So this is what I was telling you yesterday. Suppose there are 10 patients, okay, identical disease, identical TNM staging. So exactly the same set of disease, same aggressiveness, everything. But depending on their genetic makeup, if we give them the exact same drug, they will respond differently. Okay, that is pharmacogenetics. That is pharmacogenomics. So different people respond very differently to the same drug based on their genetics. And this genetics is the germline genetics, not the tumor genetics, something we are born with. Okay, so genetic variants can influence four things: drug metabolism, that means how fast the drug is metabolized in our body; drug transporters, so some people express more drug transporters, so they throw the drug out of the cell. Okay, risk of toxicity and likelihood of benefit. So these are the four things. So what that means, we are going to go into detail with real examples. So what PGX enables, it allows you to choose the right drug, equally important the right dosage. So you may need more dose than I do, and vice versa. Okay, so right dose for the right patient at the right time. Okay, so by that you can actually save people's life, because sometimes the side effects are so severe. Okay, personalized medication dosing, choosing the most effective drug, and it is extremely powerful not only in oncology but many different other diseases. Okay, so what is the difference between pharmacogenomics and precision medicine? Okay, so pharmacogenomics focuses on drugs response. Precision medicine will look at the disease and find the right therapy. It is drug response exactly, or the drug dose. Those things come under pharmacogenomics. Precision medicine will always look at the germline mutation plus the somatic mutation, especially the tumor one, right? If the tumor is expressing HER2, they are going to sequence it to see if HER2 is there, right? So really focusing on the tumor as well as the germline, BRCA1, BRCA2 deletion, right? Germline. So precision medicine will look at both kinds of mutations. Yes, go ahead. Somatic means anything which is out of germline. So germline mutations are present in every cell of our body, right? You know that. And somatic mutations are something we acquire. So tumor cells acquire mutation. So for example, HER2 is overexpressed. Exactly. So that is somatic. But if it was BRCA1, BRCA2 deficient, germline, right? So there are both kinds of it. And then you start giving the drug, and the tumors will now acquire even more mutations, right? It's a constant fight. So precision medicine has to take both into account, but PGX only looks at germline genetics. Okay. Now, this one is mainly focused on pharmacology of the drug. This is broader biology, as you see. Precision medicine looks at the whole thing. This example I will show you today, this is a very famous example, and precision medicine HER2 is a very good example. HER2 is overexpressed, you give HER2 antibody. If HER2 is not overexpressed, why would you give HER2 antibody, right? So this PGX enables personalized, safer, and more effective drug therapy. Okay, so let's look at the different things which PGX allows us to do. So PGX studies how a person's genetic makeup affects their response to drugs, including efficacy, toxicity, and optimal dose. So safer drug prescribing. So I will tell you this in details. I told you yesterday, just a little bit here. So abacavir, this is a drug. So if the people have mutation in this gene, they become hypersensitive to abacavir. This is a HIV drug. Okay, so they cannot take the drug just because they have this mutation. Now this has nothing to do with HIV itself, but it has to do with drug, how it metabolizes the drug, and because of that they cannot take it. Okay, so now in this case warfarin is a drug. People who have mutations in this thing, they have to be closely monitored for the dose. Again, I will tell you all of these in details. Okay, they're antidepressants. You have to do genetic testing of CYP2D6 before you give those antidepressants, because it will work in one person and the other person will go crazy with the antidepressant because of the drug uh, metabolism. Okay, so PGX can also tell you whether a drug will work or not work. Okay, so I will show you all of these things with examples. So if you, when implemented universally, so many times, the technician who is, or the doctor who is prescribing the drug, they just go and they feel like, okay, we should give you this just 75 mix, this and that, without like everyone who comes to their door 75 mix. That's very wrong. They actually have to do the testing. Okay, not for all drugs, for many drugs. Okay, because the drug can have extremely severe effect and the drug itself can kill the patient. Okay, it is that serious. Okay, so this is patient with same diagnosis but treated with same medication. These people had good response, they had partial response, they had no response, and they actually had extremely adverse response. And that is what is defined by PGX. So yesterday we spent a lot of time on health disparity. So this is how we address pharmacogenomics, how pharmacogenomics reduces health disparities. Okay, so why disparities exist without PGX? Again, it depends on the doctor or the technician who is prescribing. So they are just saying, oh, 75 mg worked for her, so let's prescribe the same thing. So, so drug metabolism genes vary by ancestry. So, for example, Asians will metabolize the drug differently than compared to Caucasians, but within Asia also, different people from different countries may have completely different metabolic profile for the same drug. So drug metabolism genes vary by ancestry. This is a very um, very prevalent thing. Okay, clinical trials overrepresent European populations. So most of the things clinical trials say or FDA approved, most of them are Caucasian people. Okay, people low ethnic, like trial and error prescribing harms to racial ethnic minorities, they were never included in clinical trials, so nobody knows exactly how the drug is going to work. Our patient, go ahead.
I have a question. So, in the modern drug discovery programs, all these prescriptions vary for different patients, different ages. But traditionally, maybe long ago, so in other medicines like Ayurveda, Siddha, Unani, and all those traditional medicines, so do they also have such kind of dosages for different ages or
So Ayurvedic medicine and homeopathic medicines, I don't know much about homeopathic, but Ayurvedic is for certain. Those things are not harmful for us. Okay, these allopathic medicines can be very harmful for us. Actually, I did not know. I reacted myself very strongly against some medicines. Okay, so I did not tell you the whole story yesterday. So codeine, people get addicted to codeine. And I had a surgeon, I was given codeine 2, 3 different times in my lifetime, and I was throwing up. Like I could not take codeine. I could take the pain, but I could not take codeine. And on the other hand, 90% people get addicted to codeine. They cannot live without codeine. So obviously my metabolism is different than theirs. And while I was preparing, some other drugs came, which I also have taken, and I had very severe reaction. So apparently, my metabolic pathway is different than most of them. To your question, Ayurvedic, I don't think they are harmful. They are pretty natural remedies, so they are not likely to have this effect. Now, keep in mind, not all drugs require this testing. So right now, there are 30 genes panel that they test for the drugs. Okay, if you want to do extensive, you go and go up to 100, but that is all right now. But most of the time, it is 25 to 30 genes are there, and the metabolism can really change the drug response. Now, there are very famous medicines for them, for statins, for example, right? If a particular statin is given for high blood pressure, they have to do the genetic testing, otherwise the person will die. And hypertension medicine is so common, right? So, but I think Ayurvedic is pretty safe thing. What do you think about it?
yes.
I think Ayurvedic is very natural and very safe. Allopathic medicines are the ones with the most side effects. So drug metabolism vary by ancestry. So it is all about the genetic. Okay. So, and those populations which are underrepresented are more likely to be harmed. Okay. So how PGX reduces disparity? So old model was that you look at the race, body weight, guesswork. give the medicine. The PGX model is that you actually do the testing. And it is a very easy testing. People just test, I mean, the doctors are supposed to test 25 to 30 genes all together, okay? And you can give exactly the correct drug at the correct dose. So it eliminates bias and stereotyping. So why PGX is uniquely powerful for equity? This is very important because every person is different here, and that is why it is very important to do the genetic testing. So germline based, stable across life. Once you know you have the gene, you have the gene, right? And preemptive prevents harm before it happens. You will see in some example that it is extremely severe reaction for very simple medicines, okay? Universal testing avoids selective access, actionable, clear clinical decisions. So PGX reduces health disparities by replacing trial and error and social assumptions, okay, with actual genetic evidence, okay. So there are two genomes to consider, right? There are two genomes. One is germline, something we are born with, and then there is this tumor genome, okay. Tumor genome is extremely important to find the right therapy, correct? So tumor genomes includes both inherited mutations and acquired mutations that are specific to the cancer cells. So these mutations can make a cancer more susceptible or resistant to specific targeted therapies, right? Germline is the patient's inherited DNA, and actually it is our germline DNA which decides how the drug is metabolized in our system, okay? So this part I have made it in red, and there is a reason for that, because half of the papers you will read about PGX, they will also include targeted therapy in the PGX umbrella, okay? So do you think targeted therapy should be within PGX? So think about it for a minute and tell me. So suppose somebody has cancer, right? And yesterday we went through the exercise that you guys are oncologists when somebody comes to you. So what are the steps you are going to do to figure out the therapy, right? So targeted therapy comes at what stage? You guys are going to look at the tumor and see what is wrong with that particular patient after biopsy, correct? And then suppose you find that RAF is mutated, V600E, the famous RAF mutation, then you will give the drug for that mutation, right? So should this come under PGX umbrella? Think about it for a minute. So suppose someone with breast cancer is overexpressing HER2, or somebody with lung cancer is overexpressing EGFR receptor, right? Or mutated EGFR receptor. Is this a PGX decision? Yeah. Because it is not a germline, right? So I found many talks about PGX where they have included this in PGX. It is not PGX because it is not germline, because you're talking about the tumor mutations there. However, if the tumor has BRCA1, BRCA2, and every cell of the body also has BRCA1, BRCA2, then it is PGX, right? Okay, so that is why I made this red. I was going to delete it, but then I made it red to ask you guys, do you think this is PGX? It is not PGX, unless these mutations were inherited from the parents, then it becomes PGX, okay? So these mutations are somatic mutations. It does not involve germline genetic variation. It does not predict drug metabolism or toxicity in the patient. Having HER2 doesn't tell you anything about the drug metabolism. Go ahead. Nothing, nothing. It is just targeted therapy. So this is precision medicine, but this is not pharmacogenomics, right? So you guys have a clear understanding between the two, right? So germline genome is something we are born with. It is inherited. It will not change over time, okay? And PGX test variants in the genome predict drug metabolism, toxicity, and response. PGX does not primarily use somatic genome. So keep in mind, when you go back and you look online, you will see people have included somatic mutations. That is not PGX. Okay, they have made that, they have made this umbrella, they have added it here, but it is not. Okay. So PGX is germline, tumor genomics is somatic mutation. This is inherited DNA, this is tumor DNA. This is, look at the things it is doing. Main goal is the right dose to predict toxicity before you give it and efficacy before you give it. This is allowing you to select the drug. HER2, you accordingly select the drug. Okay, this is here pharmacokinetics and pharmacodynamic, they are very important. I'm going to tell you about that. And here only pharmacodynamic, and these are the examples. Okay, so I will give you the examples in great details with their functions. So this is the simple comparison. So this is germline. Every cell of our body has a mutation. So if you have to test, you just take the saliva, because every cell, including our saliva, has it, right? Here you have to go to the tumor tissue to do a biopsy. Makes sense? Lifelong, this is when the disease is there, that's when it is there. Drug response, this is tumor biology. So now you guys understand. So this is, so look at this. I've already told you about this, right? So these are PGX germline, and this is tumor genomics here, okay? And the key difference also we discussed. Now let's look at some real examples. So this is what I was telling Venkatesh, that usually they test very few genes. They can only test these many genes, and they don't have to test it for like several medications. They know they are safe. But for many, they have to test before they can prescribe. They should not prescribe for many. So core clinical PGRs are 15 to 20 genes, and doing a PCR of 50 to 20 genes is a piece of cake. Most clinical PGX panels include 20 to 30 genes. If somebody really wants to do a real extensive one, it's 50 to 100 genes. Okay, especially if you're really going after something, some really novel drug, then probably it is a good idea. Okay, so this is tumor genome, this is the germline genome. Okay, so let me briefly tell you about pharmacokinetics and pharmacodynamics. So pharmacokinetics and pharmacodynamics, like I said here, okay, in this one, where did I say here? Here, in germline, in PGX, these two things are very important. So I will tell this again in the next lecture, but very briefly, pharmacokinetics is what the body does to the drug. Okay, how quickly it is metabolized, whether it is absorbed, how it is distributed, how quickly it is excreted from the body. The whole ADME panel is pharmacokinetics, and it makes sense. This comes under PGX umbrella. And pharmacodynamics is what the drug is doing to the body. Okay, so target binding, biological effect, clinical response, that is all pharmacodynamic. Okay, so germline genome actually determines the pharmacokinetics, pharmacodynamic, and finally the clinical outcome. So the variants, because of that, pharmacokinetics will be altered because the drug levels will be altered. So it's very simple. If a drug is metabolized very fast, the levels are going to be low. If the drug is metabolized very slow, it is going to be high. Very simple. So if I have an enzyme which will metabolize it fast, drug will not stay. So I have to be given higher dose. But if it is not metabolized in someone else's body, they have to be given lower dose. Now suppose I take a statin, right? And that statin is supposed to go to the liver, and I have a mutation in a gene in the liver, so the statin doesn't go to the liver. So what will happen? Statin will circulate in the blood because liver is not able to take. So when the levels of this drug gets very high in the blood, so the doctor will say, oh, give her more statin. But the thing is that forget about giving more statin. Whatever statin I have taken, the regular amount, that is accumulating in my blood because liver is not able to take it. So that itself will kill me. Forget about increased dose there. So that could be actually fatal. So it's very important that if you're aware of these kind of things, you have to do the testing before you give the drug. Okay. So this is so genetic variation in drug metabolism enzymes. We don't have to do 1,000 genes. We know the key genes, key proteins which are involved in drug metabolism, and these are some of them. So these CYP2D6, determines whether metabolism is going to be fast or slow. This determines poor metabolism, drug failure. If this is not working, poor metabolism, drug fails. We take it, it is not useful in our body. This one determines the clearance in the body. So let's go to the actual examples here. So before I go to the actual examples, so how pharmacogenomics personalizes cancer treatment, it helps in optimizing drug dose, which makes sense. If drug is metabolized, I is missing here, sorry. If a drug is metabolized too slowly, it can build up to toxic levels causing severe side effects. If a drug is metabolized too quickly, it will be cleared from the body before it can have a therapeutic effect. Predict and minimize toxic side effects, obviously, right? And you can tailor it exactly to the person, okay, the person's genetics. All right. Oh, did you take the picture? Should I go back? Should I go back? You took it. Very good. Okay. This is now, let's look at the real example. Okay, you will get all of these things tonight. I did not, today again, the internet was jumping around, so I could not send it to you because it was on and off, but it was just temporarily, so it's not a problem. Okay, so let's now look at real example. Okay, so what happens is that in blood cancer, in leukemia, these drugs are given. It's very simple. 6-mercaptopurine, azathioprine. So this is azathioprine. This is 6-thioguanine. 6-thioguanine. This is 6-thioguanine, and this is 6-mercaptopurine. Okay, so you can see this is purine, and if you put NH2 group, it becomes guanine. Okay, and this is AZA-T. So these drugs are given to leukemia patients, but they do not work. If you give it, it is not going to work directly. They are further metabolized in our body before they become actually a drug. Okay, so after administration, these three drugs have to be metabolized to become active. Basically, you make the triphosphate of this thing. Monophosphate, diphosphate, triphosphate, just like ATP, GTP, UTP, TTP, right? So when they say metabolize, you are actually making the triphosphate. So in AML, mercaptopurine is the primary thiopurine used. Okay, so mercaptopurine after administration is converted to the corresponding mercaptopurine triphosphate, just like ATP. Okay, so this one, so they call it TGNs, triguanosine nucleotide triphosphate, causes DNA damage in cell death, which has the desired therapeutic effect. So one of the ways to kill the cells is that instead of, so you know all DNAs, they need ATP, GTP, TTP, and CTP, right? No UTP. UTPs are for RNAs, right? So they need that. So you could, so adenine ring and guanine ring, right? So what is the substitution in adenine? NH2 group, right? If you have a purine ring, if you put NH2 at the C6 position, that is ATP. If you put NH2 at the second position and ketone there, it becomes guanine. So look at the structure here. So if you normal case, you will look at this structure here. It will, if you, this is O and this is NH2. So all you replace S with O, it becomes guanine, right? It is thio-GTP basically. So this is, if you attach the sugar, it will, and phosphorylate, it will mimic GTP, except it is thio. This is purine. So here you have NH2 group in the case of adenine. So basically the point here is that when you give these things and when they are converted to the corresponding triphosphate, DNA polymerase can mistakenly add this in the DNA thing, and then the DNA will be damaged and basically the cells will die. That is the point of giving these drugs. Okay, so let's see what happens. So when we give these drugs, when we give AZA-T, it is converted to 6-MP, 6-mercaptopurine, or we can directly give 6-mercaptopurine. And 6-thioguanine. So then what happens inside the cell? There are these, do you guys know which kinase phosphorylates the purines to the corresponding monophosphate? Have you read that? Probably not read it so far. So there is, so suppose you have guanine, then there is, suppose you have guanosine, because you have to attach guanine to the sugar, sugar before it can get phosphorylated, right? So guanosine is phosphorylated to GMP by guanylate kinase. Adenosine is phosphorylated to AMP by adenylate kinase. Cytidine is phosphorylated to the corresponding CMP by cytidylate kinase. Thymine, thymidine is phosphorylated to TMP via thymidylate kinase, right? So these guys are phosphorylated now, okay? So this is such a small difference between GMP and thio-GMP that the guanylate kinase will convert 6-TG once the sugar is attached to 6-thio-GMP. GMP will be converted to GDP. GDP will be converted to GTP. Okay. Now, once this is my mistake, I said something wrong here. Guanylate kinase comes here, GMP to GDP, not from this to this, my mistake. So guanylate kinase will be here. This is attached to the sugar with the phosphate directly. Okay, that is not relevant to you, but I want to be completely accurate. When you go to monophosphate to diphosphate, that's when the guanylate, cytidylate, adenylate kinases will show up. Okay, not directly from the sugar to the monophosphate. Monophosphate to diphosphate is the kinase. And then there is common kinase called NDK that will convert any DP, any diphosphate to the triphosphate. Okay, but here is a relevant part for us. So basically the cellular kinases will convert GMP to GDP to GTP like here. And this will get incorporated in DNA or RNA and damage it, and the cells will die. That's the principle. But what happens is that in most of us, we have this protein called NAD-T15. So NAD-T15 hydrolyzes GTP back to GMP. This GTP back to GMP. So because of that, it keeps relatively low levels of 6-thio-GTP. And is it making sense? Right? If this is absent, or if it is not functional, or if it has very little activity, then these guys accumulate. And if they accumulate, they will kill the normal cells, and it will create so much toxicity that the person may die. So you are giving a simple leukemia drug, and that can actually prove fatal if NAD15 is missing. So NAD15 breaks down toxic thioguanine triphosphates to the corresponding monophosphate. If NAD15 levels are low, then there is huge bone marrow toxicity. Okay. Now, this is another example, another enzyme, TPMT, thiopurine S methyltransferase. So remember this one here, this compound azati, and this one here. So it takes this 6-mercaptopurine and it methylates it. Okay. So because of that, it keeps the level low of this compound. If 6-TMP, so it inactivates thiopurines by methylations and clears it from the body to maintain low level. If this is not working, too much of TGN accumulates, and if TGN is accumulating, basically too much bone marrow toxicity. Go ahead. No. It is, you mean the compounds or the enzymes? Oh, yeah. We have it. I will show you, actually. I have a very interesting slide here. Okay. So just give me 1 minute. I'll come to that, and that will actually show you who expresses it and who does not express it. Okay. So if TPMT or NAD-T15 is deficient, less activation, excess TGTP buildup, thio-GTP buildup, bone marrow suppression, which can have a severe consequence. Okay. So these two, both of them lead to bone marrow toxicity, neutropenia, anemia, and all of these things. Okay. So look at this. This answers your question. So TPMT, most common in Europeans and Africans. Okay. NOT15, more common in Asians and Hispanics. See, it is totally ancestry based, totally ancestry based. So, TPMT deficiency fails to inactive 6-mercaptopurine early. That leads to myelosuppression. So, what you have to do, you have to reduce the dose. So, if you have to give this dose to a patient with leukemia, you have to give low dose, otherwise the toxicity is going to be too severe, because whatever little dose will get converted to TTP, right? But then it will not be cleared. So you have to give really low dose. NOT15, this is even stronger thing. So you reduce the dose. So rapid, severe early neutropenia. So you reduce the dose even more. So keep in mind, for this leukemia, it is absolutely essential to do a genetic testing before you administer this drug. Okay. Poor metabolizers due to TPMT are at extremely high risk of life-threatening myelosuppression with standard thiopurine doses. I'm sorry. And require drastic dose reductions. Okay. So there are, high metabolizers, intermediate metabolizers, and then very low metabolizers. If you have one or the other deficiency, it's bad. But if you have the deficiency for both, it is extremely bad. Then you have to give really tiny dose. Okay. And we are talking about leukemia here. So you have to give the drug. So the drug itself is toxic, and then the dose can really be very important here. So it can be poor metabolizer with loss of function, not T15 variant, have absent or intermediate metabolizers. And poor metabolizer are at very high risk of severe myelosuppression and require drastic dose reductions. Okay, intermediate are obviously also, but they have to be given intermediate dose, lower dose. Okay. So combined, if both of them are there, then it is extremely severe. Okay. All right. So that is why all these consortiums, okay, they have recommended pharmacogenetic testing for these things. So before you give this drug, you have to do the testing. Okay, so genotyping results guide a patient's starting dose and help mitigate the risk of severe toxicity. Okay, so okay. Second thing is the drug transporter. So that was metabolism, right? This was metabolism. One drug was getting metabolized, the other one was not getting metabolized, cleared. The second thing is drug transporter. So some people, they express huge number of transporters. So what are transporters? You give the drug and they throw it out of the body. So these are efflux pumps. They throw the drug out of the body. And these are ABC transporters. So if they're throwing the drug outside the body, outside the cell, you have to give higher dose, right? Because they keep throwing the drug out of the cell. It will not have the therapeutic effect. Okay, so go ahead.
So these drugs are captured by some enzymes and then they are effluxed out?
No. Just give me 1 second. So most of these drugs are cell permeable. So you give them, that's why it is showing you it is lipophilic molecule. It comes inside. And then what happens is that in response to these drugs coming out, these efflux pumps either are already present or they are going to be upregulated. And then they will efflux the drug out. So many cancers, you give the drug initially and they have very good response. And after that, they stop responding. And it could only be due to the upregulation of these efflux pumps because they are just throwing these out. One time back in 2001, when gene chips were just made, so the director of our institute was the one who made it. So it was not even commercially available to other people, but we had it in our institute. So I added a very simple compound, a purine-based inhibitor, and we did gene chip thing. The first thing which came up was a drug efflux pump. You treat them for just a few hours and efflux pumps are upregulated to throw it out. So that is a natural response, and in cancer, that is very prevalent. So the intracellular drug levels will obviously go lower, but it can be inherent. It can be an inherited thing, so that there are more drug efflux pump. Okay, so reduced efflux activity, that means more drug is going to be there, so you can have lower dose. Higher efflux activity. Other polymorphisms are linked to higher PGPs, that efflux pumps name, expression, or enhanced activity, which more effectively pumps drugs out of the tumor cells. So the drug's effectiveness is reduced, so you have to give them higher dose. Okay, and many times they do not fold properly or something, so accordingly you have to decide the drug dosage. Okay, now, so this is a major cause for drug resistance, upregulation of these efflux pumps. Okay, so breast cancers, so this is the same, PGP1 is the same as ABCB1 thing. So many studies have explored the association between these efflux pumps and breast cancer outcomes. And so when you have upregulation of this drug, and paclitaxel is a chemotherapy drug, right? So paclitaxel is a very important chemotherapy drug, but if this efflux pumps are out, those patients do not respond to paclitaxel therapy and they die much earlier. So it's very poor prognosis. These efflux pumps are upregulated, poor prognosis, because the drug is not going to work, okay, because it will be thrown out. See, in leukemia, if the pumps are highly expressed, it causes resistance and poor patient outcomes. Yes.
What are the reasons behind that efflux pumps are getting activated?
So it could be a germline mutation that they express this thing. It could be inherently in that person. Second thing is that it is also upregulated in response. So the way our body is built, a lot of foreign things come in our body, so it's a natural response to get it out of the thing. So this was built to protect us from that. But when we are taking the drug, the body actually doesn't know whether it is good or bad, right? It is a foreign thing. So its natural response is to upregulate the efflux pumps. That's what I was saying, even in the cells, right? These cells, it's not a human body, it's not an organism. You add the inhibitor, efflux pumps just are turned on.
What do reflex pumps are ultimately a chance protein? So what do those proteins exactly look for in a molecule to pump it up? Is there some specific, or is it just
There are some specific, there are many different kinds of pump, but they are not 100% specific, otherwise they will keep on changing, right? So they are pretty generic. They take it, they use ATP energy, they just throw it out.
I was thinking in the sense of if we could make change the conformation of the drug that we are delivering, so that maybe the
They are
pumping
too
could-
smart. The more complicated drug you make, they will throw it out. Yeah. But then the way to overcome that is that you use PGP1 this PGP pumps inhibitor. You give the drug and you use those inhibitors, then they cannot pump it out. You give them something which they like more, they are shut down, right? Ovarian cancer has the same thing, okay? Upregulation, chemoresistance. So, so pharmacogenomics improves treatment efficiency, it reduces adverse drug reaction, and you can personalize it to a person, okay? If challenges are obviously, if there is no facility to do genetic testing in some region, that could be limiting. And for many drugs, we know that these are the pumps and we do genetic testing. But suppose in Asian, in Native Americans, right, testing have never been done. So we don't even know what kind of mutations exist there. So we don't even know what to look for. So these people may suffer who have not been included in clinical trials, right? Because most of studies are coming from European ancestry people, okay? And it is obviously a little bit expensive, not that expensive because it can be tested by PCR, but it has a higher cost of implementation. Wow. I know my first two lectures are short. आप उसको बंद कर सकते हैं 1 मिनट के लिए. First two lectures are relatively short. The other two lectures are really long. It is just the topic is like that. So let me go to the next lecture right away. Okay, it's anyway 45 minutes, so it's okay. Actually, I walked in, I started talking. So that's why I was having this thing. I need 5 minutes to get acclimatized. I'll start Venkatesh, the next one, the next lecture, because usually we have a break at this time. Yeah, so let me start the other one, because third and fourth are pretty intense here. And the second lecture is anyway part 2 of this story, so we can continue with that. So some of the slides are the same, just introduction to pharmacogenomics here. So when we give a drug to a patient, even after we do the targeted therapy, many factors determine the efficacy of drug. So, height, body weight, sex, age, disease, all of these are contributing factors that how the patient will respond to a drug. Okay, organ function, physiology, environmental factors, all of them feed in. You give chemotherapy to a young person versus an old person, a healthy person versus a non-healthy person, regardless of age. They, they all are going to react differently based on that. But, and so drug could be toxic or beneficial. I have not taken too many prescription drugs, but I have reacted very strongly to few drugs. Even I have. And I could not figure out why I have such strong reaction. So up until recently, I did not know. And now I know that there is something different about, my metabolism. So, but pharmacogenomics is this part only. So this is one part we are considering out of so many different things here. Okay, so this you already know. So this is just showing you the advent of pharmacogenomics. It's a relatively new thing. So this thing, FDA approved pharmacogenomics biomarkers like the one I showed you in that table just in 2014. So it's a very recent thing. People did not even understand this thing. Okay. So this is just to show you that some people really respond well to a drug, same disease, same intensity, everything. Other people have no effect. Some people have side effect. Other people are hospitalized because of that. And there's all this thing, and you have to give a huge variation in dosage. Okay, so one size does not fit all. Okay, there is a variability in response, severe toxicity, therapeutic failure, and many times people are hospitalized with serious thing. Okay, so the key determinants in pharmacogenomics are pharmacokinetics and pharmacodynamics. Okay, so pharmacokinetics is the one which I just told you, right? Can you remind me what is pharmacokinetics? ADME, very good. ADME, right? What the body is doing to the drug, exactly. So that will determine drug's level, right? Body gets rid of it quickly, it's not there. Body's letting it metabolize slowly, it is going to be there. And pharmacodynamics, what the drug is doing to our body, very good. Okay, and these two things are the main determinants for pharmacogenomics here. So pharmacokinetics, what the body does to the drug, which is ADME. ADME, if you don't know, it is ADME, right? So many of you will make small molecule inhibitors for something, for some disease, right? So once you do it in cell line and test it, and you're testing in animal model, right? Then you have to do ADME, right? Then pharmacodynamics, what the drug is doing to our body. We saw many examples yesterday also. Germline and somatic mutations, germline are inherited from patients. PGX deals with germline mutations. Somatic are the somatic with respect to cancer is mainly about the tumor, right? If the tumor, what exactly is wrong with the tumor? This is a very famous mutation. Now I'm going to give you some examples. So suppose there are 4 scenarios, right? So this kind of tumor is overexpressing the receptor. This has fewer receptor, this has no receptor, it has different kind of receptor, okay? And let's say it is HER2 receptor. So if you give Herceptin, it is going to be very effective here because it has too many receptors. This will probably also respond. This is not going to respond because there is no HER2 there. And then this is going to respond or not? The last one? No, because it is not meant for this receptor, right? So this will have no response. So does this come under PGX umbrella? Raise your hand if you think it is yes. Thoda sa upar so that I can see it. Okay. And raise your hand if you think it is not under PGX umbrella. If your answer is no, raise your hand. You're the only one who is right here. Provided we feel like we have achieved such a big thing, right? We all do. I also feel the same way every single time. Okay. Okay, to make all of you who raised your hand right, what would you like to see here to make it come under PGX umbrella?
Because the receptor, like the formation of receptors are encoded in genes. So that's why I'm relating it to the
Germline. So what is the difference between germline and somatic mutation?
somatic cells are like every cell of our body. Germ cells are the.
It is the other way around.
Is it?
Yeah, it is that. I was going pretty quickly because I was thinking you guys got it, but I'm very glad you got confused because I'm sure somebody else is also confused about that. So what happens is that germline means egg and sperm, right? So when the zygote is formed and when it divides, basically every cell of that particular progeny will have that mutation. So it is a germline mutation. In cancer, when we say somatic, we are basically talking about the tumor itself, right? So that is somatic. So that tumor, whatever mutations have been acquired there, that may not be germline thing. So like we were born healthy, we remained healthy until 70, 80, whatever age, and then somebody develops a tumor. So it's obviously not germline thing, right? There was some environmental change or whatever it was. Something external went wrong to give rise to that tumor, right? So that's not germline, that is somatic.
But also, somatic will have this 23 pairs of chromosomes. Germ will have only 23 chromosomes. Is it?
No, so once the zygote is formed, your pairing is all done. So it depends on the parents. So for example, cystic fibrosis, right? So the father is the carrier, mother is the carrier. So one defective gene in each of them. So, and cystic fibrosis is very uncommon in India, okay? Very, very uncommon in India. It is very common in people from the Western world. But my friend, she was a carrier of cystic fibrosis. Obviously, she had no idea. And her husband also turned out to be a carrier of cystic fibrosis. And when they had a son, he has cystic fibrosis. And cystic fibrosis, you know her, I'll tell you later. So when cystic fibrosis, some time ago, the average age was 12 years. Then 16 years. When my friend's son was born, it was 20 years. And the good news is there now it is better. So she was very worried. And I don't know, I was putting together this presentation, and cystic fibrosis is one of them. So I checked her son today online to make sure he's all right. He's the president of a very big financial company, and I'm sure he's in his 30s or late 30s or something like that. I didn't calculate. He's 1995 born, so 30 years old. So he's all right. He's doing very well, so that's the good news. But when he was born, the average age was 20 years. So my friend was hoping by the time he grows up, some therapy comes, and now there are many therapies. So the point here is that some disease will show if you have only one allele, but other diseases will manifest. And they're both from Kashmir, so they are Indians. But and it is extremely rare to have that mutation in Indians. But it happened just that the two carriers got married and the child has it. But the child has 1/4 chance of getting it, you know, the Darwinian rules. But go ahead.
Very high chance of possible for somatic mutation because cystic fibrosis occurs within 5088 mutation.
There are more than one mutation, and there are more than one ways of having cystic fibrosis. In some cases, the channel is defective. In some cases, the channel is not made. So there are many variations of cystic fibrosis also. And if it is somatic, your child cannot get it. Your child will not get it if it is somatic. Because it has to come to the egg and the sperm before it is transmitted to the progeny, right? So those of you who raised your hand, right, justify this why it is a PGX. You can justify it. Sometimes when we make a mistake, we justify it. Especially as children, we always try to justify it, right? So you can actually justify it scientifically. Can you justify it?
Inherited from the parents.
Exactly. Then it could be PGX, right? So if we inherited this from our parents, that we have too many receptors, that's a different thing. Then the person will get this tumor as a child, right? Because it is an inherited thing. If it was inherited, then it could be a PGX. That most of the time, this kind of thing is not inherited. This is a tumor-specific thing. In that case, you guys are correct. Okay. So when receptor differences are PGX, if the difference in receptor type, structure, expression is caused by germline genetic variation, then it is PGX. But if it is in the tumor, somatic, it is not PGX. Okay, germline, yes. Epigenetic disease, drug exposure caused it. No, it is not PGX. Okay, tumor mutation, not PGX. Okay. So receptor differences are PGX only when they are caused by inherited genetic variants. Okay, same thing about this thing. So this cell has a lot of receptors to take this drug. So drug gets in. This one has less receptors. So if your cells have decreased uptake of a drug, the drug can build up and cause problem. Is that PGX? Can you tell me that? It can be PGX if only the decreased uptake is caused by inherited genetic variation. It's as simple as that. Okay. So when decreased uptake can cause toxicity, if cells cannot take up a drug properly, drug remains in the blood or extracellular space, systemic concentration increases, that can be toxic. So there is a problem there. You take a drug and it is not taken up. So it is not going to be effective because it is not reaching its destination. Plus, because it is not taken up, the blood levels are going high and high. The drug, so it is causing toxicity. So both ways it is a lose-lose situation, right? Okay. Again, if the decreased uptake is PGX, if only it is due to the germline variants, okay? When decreased uptake is not PGX, because it is due to drug-drug interaction, or there is organ damage, or there is inflammation, or hypoxia, or something else, then it is not PGX, okay? Drug breakdown. So normally the drug is breakdown, so you give the normal dose of the drug. If it is fast breakdown, you have to give more drug. If there is less breakdown, you have to use less drug. Okay. Okay, we can stop here. Okay, we have tea time, so let's have tea and then let's talk after that. Okay.
We have a 15-minute tea break, so please rejoin after 15 minutes.
Okay.
Thank you.
All right, let's get started. So, this is just telling you about targeted drug development. This is not necessarily pharmacogenomics unless the target in the cancer cell is an inherited gene. Okay, so now let's look at the case studies. Okay, and that will tell you the significance of pharmacogenomics. So, statins, you know, these are given for high blood pressure, right? So, there is many people. So for statins to work correctly, they may first be taken into the liver. Statins are transported into the liver by a protein made by this gene. So you may not know this thing. Many times genes have a different name than the protein. Many times the protein names and the gene names are same. Other times they are not the same. So remember that PGP1 I was saying, that is the gene name. Gene name was that ABC, all that big name, and the protein was, yeah. So this is the gene name SCLO1B1 gene. Okay, so some people have a specific change in this gene which causes less of a statin called simvastatin to be taken in the liver. So when taken at high doses, this drug can build up in the bloodstream. So this can cause muscle problem, including weakness and pain. So simple blood pressure medication. So it is not going in the liver, so it's not going to help the person because the drug is not going to work, but it is building up also. Actually, that is not true because the liver is not the one which is affecting a liver is just metabolizing the drug. All the drugs are basically, most of the drugs are cleaned up by the liver, right? So if it builds up in the blood, it will be toxic to the patient. Okay, so if the doctor is prescribing this drug to you, then that doctor should test for this gene. So see, here it is not going in the liver. Okay, here it is going in the liver, here it is not going. So look at that, how much it is building up in the bloodstream. Okay, this is another case, depression and amitriptyline. So this is an antidepressant drug. Okay, so the breakdown of this antidepressant drug is influenced by two genes called CYP2D6 and CYP2C19. So if your healthcare provider prescribes amitriptyline, they might recommend genetic testing for these two genes to help decide what dose you should do. So what these proteins do, if you take amitriptyline, it demethylates to form nortriptyline. Okay, and this nortriptyline is then hydroxylated to these products. So either amitriptyline is directly hydroxylated or nortriptyline is hydroxylated. So if you break down amitriptyline too fast, you will need a higher dose for it, or you may need to use a different drug. If you do break down very slowly, you may have to take smaller dose there. Okay, have you guys heard of this drug, amitriptyline? You have. In what respect? In serotonin receptor. Some doctors also prescribe it for headache. It is not a headache medicine, but they do prescribe it for headache also. You know that? Have prescribed for headache. Did it work for that person?
It did, but these were very hesitant because it was an antidepressant drug. So we did ask for another opinion.
But it is an antidepressant drug.
This drug is also used for during traumas if someone is having trauma. I have seen.
And did it help? It helped. Okay. Let's talk about it at lunchtime. Okay. Okay. Cystic fibrosis. Okay. So cystic fibrosis is caused by genetic changes in this gene called CFTR gene, which affects the CFTR protein. So what this does, this protein forms a chloride channel which acts as a passageway to move chloride across the cells in your body. So it looks like that. So cystic fibrosis patient, either they don't have this drug or they have a defective channel there. So what it happens is that chloride cannot go this, and water is also, I don't know, water can go, but these people, they develop mucus in their lungs and infection in their lungs, and basically it's very bad disease to have. So they have to do extensive exercise. They have to live in extremely clean environment, and possibly even isolated from the rest of the people because they cannot be exposed to just everyday's, germs. Okay, so this is showing you when there is no cystic fibrosis, things can go in and out of the channel. Now, if you give this drug, ivacaftor, and this is a cystic fibrosis damaged this thing in a patient. So if you give this drug, it opens up the channel and things can go back and forth. So this is good. But there are also cystic fibrosis patients which do not even have this channel. So if you give this drug, it is not going to work because it can only open up the channel. If the channel is absent, the drug is not going to work. So basically, before you prescribe such drugs, you have to do genetic testing to see exactly what it is. Okay, then we come to Herceptin. So Herceptin, as you guys know, it treats HER2 positive breast cancer. It binds to HER2 receptors, and this is overexpressed due to specific gene profile in the tumor. Okay, now 5-fluorouracil. So tell me this one. Is this a PGX umbrella? It is not a PGX. I did not remove it because it was supposed to be a question thing for you guys. So this does not come in PGX umbrella. But again, if you go in literature, some people will put it in the PGX umbrella. It is not. Okay. Okay. This is another one. This is 5-fluorouracil and Zeloda. So 5-fluorouracil is a widely used chemotherapy agent, and this enzyme DPYD is responsible for the breakdown of more than 80% of the administered 5-fluorouracil in inactive metabolites. So when that is absent, 5-fluorouracil accumulates to toxic levels, leading to massive cellular destruction. So basically, chemotherapy will kill the person, right? So before this drug is administered, one has to test for this enzyme, whether it is functioning or not functioning. So standard dose, more than 80% is inactivated, but when these variants are there, nothing gets inactivated, which causes lethal toxicity. Okay? So this is that drug. It is just showing you that it inhibits thymidylate synthase. Do you guys know which enzyme is thymidylate synthase? Have you ever heard of? Very good. It is involved in folic acid synthesis. But what is the role of thymidylate kinase itself? It forms thymine. The thymine thing is the CH3 group which is attached there. That is thymidylate synthase thing. It is involved in folate receptor pathway. You know why? Because THF, tetrahydrofolate, is the methyl donor for thymidylate synthase. Okay. So, say that part again. Oh, I am not going to answer till you use that. That's what we figured out yesterday. Yes, go ahead.
So those drugs we were like you said earlier, mercaptopurine, then 5-fluorouracil. These are antimetabolites which act as a pseudo like nitrogen basis. So they inhibits this DHFRase and this synthase enzyme.
So there are slightly different mechanisms. So when you have 6-mercaptopurine, it has nothing to do with thymidylate synthase or DHFR, because they get incorporated in DNA and RNA and they basically damage it because they are not the natural basis. So that is different. But when you are using 6-fluorouracil, right? So your 6-fluorouracil is this compound here. You attach the sugar here, right? So this is 6-fluorouracil. And what is thymine? It is this thing here. So if you put the fluoro group here, it is mimicking thymine, right? So this can actually inhibit thymidylate synthase. So this is different from 6-mercaptopurine versus 6-aza-T, because they are actually getting incorporated in DNA. Okay, so so this is very toxic to the cells, but it has to be cleaned up, and if it is not cleaned up, it will kill the person just because of that. So you're giving a drug without testing, and you're basically killing the person. Okay, because 80% is inactivated, right? Okay, now, so this is a real world case. This is actually a real case. He's the doctor here. So standard drug for this 6-fluorouracil prodrug, it is given as a prodrug, which then becomes 6-fluorouracil. So this capecitabine is given. So within one cycle, this lady, she developed grade 4 mucositis, severe mouth ulcers, grade 3 diarrhea, and had foot syndrome. And genotyping revealed that she was heterozygous for this gene. So somebody was asking me, I think Venkatesh, you were asking me that how do you know, or who was asking me, I'm sorry. Somebody, one of you were asking me, how do you know which drug to, okay, yeah, you were asking me. Can you remind me your name again? Anshul. Anshul.
Anshul.
I heard Anshu, by the way, that time. Anshul, yes, Anshul was asking me. So when this doctor gave the drug to her, obviously this was not known, but then at least he figured it out that this is the problem there. So now anyone who would give this prodrug, they should test for this before they give this therapy. Okay, so this is a consortium. So there are the guidelines for DPYD. If it is a poor metabolizer, that means it is not metabolized, don't give this drug. If it is an intermediate metabolizer, do 50% dose reduction. Only if it is a normal metabolizer, you can give this drug, okay, at the recommended thing. The next one is UGT1A1 and irinotecan. So irinotecan is a product converted to SN38 active metabolite, which is 1,000 times more potent. Okay, and this enzyme UGT1A1 conjugates SN38 for biliary excretion. So obviously, if you have problem in this variant, and if it is less active, reduced expression of this enzyme, they are at higher risk for severe diarrhea and low white blood cells. Okay, so genetic testing is required. Okay, so suppose you are reacting very strongly to some drug and people are normally taking that drug, so that is probably telling you that there is something genetic in our body that is not allowing that drug to be used.
This enzyme conjugates means it forms a covalent bond.
It forms a covalent bond and gets rid of it. I've not included the structure, but I have seen this thing many times, and I was trying to recall SN38 because it has come across many studies, but I can't remember. So sometimes they attach a lipophilic something and get rid of it. So imagine that 80% is excreted. Yeah, so that is it has to be cleaned up pretty quickly because these are pretty toxic stuff. Tamoxifen is a drug for breast cancer, right? My friend, she had breast cancer long time ago, long time before I met her, and she was completely cured because of tamoxifen, like 100% cured. No, this is yet another person. No, just tamoxifen completely cured her. And when she was in her 20s, and when I met her, she was in her 50s. So tamoxifen is used for breast cancer prevention. This is tamoxifen here. So this is metabolized to 4-hydroxytamoxifen, and this is also converted to this compound and this compound. So there are many enzymes involved in metabolism of tamoxifen. So tamoxifen is a prodrug with weak anti-estrogen activity. So what that means is that you all know that females, they have estrogen hormone and males have testosterone. We all know that, right? So many drugs, especially like breast cancer, there is a kind of breast cancer which feeds on estrogen. So more estrogen, more growth of this thing, right? So this is tamoxifen is anti-estrogen. The reason the spelling is weird here, Okay, it's not weird here. Estrogen is written in two different spelling. Estrogen is ESTO, and some countries it is written as OESTRO. So you will see both the things depending on from where I took the figure. So tamoxifen mimics estrogen, but it is not estrogen. So it will bind to the same receptor, but it will inhibit the signaling pathway. Okay, so and then it requires bioactivation to endoxifen, right? So tamoxifen is given and then it is converted to this, and this is 100 times more potent than tamoxifen. So poor metabolizer will produce very little endoxifen, receiving a placebo effect. Do you guys know what is that? How many of you do not know what is a placebo effect? Because it's a very fun thing. Or you don't know that, right? So whenever they do clinical trials, right? Whenever they do clinical trials, I have a slide for clinical trials also, which does not fit anywhere in any of the lectures. So I put at the very end of one of the lectures today just to tell you what exactly is going on in clinical trials and what is phase 1, phase 2, phase 3 clinical trials. But you know there are these clinical trials before the drug is approved. So in clinical trials, it is a necessity that suppose they take 100 patients. So they will tell these 100 patients that you are all receiving the drug for the same disease. Whatever these 100 patients have the same disease, right? So they say, oh, you are all, they do the consent that if something goes wrong, they are not responsible. So they take the drug, but they don't give the drug to everyone. A large portion of them will get sugar pills or some useless pills, right? But the person will think they are getting the medicine, right? And many times those people who are getting sugar pills, they get cured. The people who are getting medicine are not cured. And this is a very, very strong thing. So that is a placebo effect. You believe so strongly that you are getting such a wonderful medicine that you get well. That is called placebo effect. So when a drug works, they look at what percentage of people had placebo effect before they say the drug has worked. If a large people just got well because of the placebo, probably the drug wasn't working. Okay, that is placebo effect. So here it makes sense that if this enzyme is, either of these two enzymes are not going to work, this is not going to work. And if the cancer is disappearing, that is a placebo effect. It's not the real thing, right? That is why we always tell if somebody is suffering from a disease, right? You have to keep the moral up that you are going to get well, you are going to get well, you are going to get well, because that placebo effect can really do miracles. You cannot say a negative thing to a person with a serious disease. Okay? So endoxifen is 100 times more potent than tamoxifen. Okay? So poor metabolizers, if these enzymes are defective, endoxifen will not produce, and it is basically placebo effect. So studies have shown that patients with poor CYP2D6 metabolizer genotypes are more likely to experience breast cancer recurrence. It will come back with worse survival rate, which makes sense, right? And clinical applications. So pharmacogenomics testing can identify patients who may not benefit from tamoxifen and could be a candidate for alternate therapy. Okay, so this is very serious thing, pharmacogenomics. Okay, and now it is so this is estrogen receptor. So estrogen comes in, binds. This is a nuclear hormone receptor. So they go in and bind, and they turn on the signaling. Tamoxifen binds at the same place, but it does not turn on the signaling. So that is how it switches the signal off. Okay. All right, so precision medicine, we all know how important it is, but now you understand how PGX is equally important along with precision medicine. Okay, so somatic pharmacogenomics, I included this to give you an idea. So literature is filled of pharmacogenomics where they have included non-germline mutation, and they label it somatic pharmacogenomics. That means the tumor pharmacogenomics. This is not classical pharmacogenomics, but they still use this quite a bit. Okay, so if you are going there and calling it somatic pharmacogenomics, which is not the classical PGX, then obviously every mutation in the tumor will be counted under this umbrella. Okay, all right. But once again, let's stick to the fact it is gene-based, germline gene-based thing, okay? And these are the main things which are tested: drug metabolism, drug transport, drug response. These are the things which are included in this thing. This is genotyping, which is very, very easy, right? You can do targeted genotype, PCR or Tachman assay. Many of us do PCR all the time. It's so easy. Next generation sequencing, turnaround time. Treatment often cannot wait 2-3 weeks. Who takes 2-3 weeks for PCR, right? When COVID was happening, they took my mouth swab. I was feeling sick one day and I was thinking maybe I got COVID. I did not have COVID, but at that time you felt slightly sick. You thought it was COVID. It was right of it. They took it, and 1 hour later, by the time I went home, they told me I didn't have it. So it doesn't take 2-3 weeks, but okay, structural pharmacogenomics and functional pharmacogenomics. It's not that important, but I will still tell you the significance of that. Structural pharmacogenomics means genetic variants due to the change in the structure of the protein that it is doing. It's like CYP2D6, right? So if this is not working, that means there is some mutation in the protein. That is structural genomics. But can you tell me some other way that there is no mutation in the protein, but it is still not working? Can you tell me any other way?
Enzyme inhibition by any other drug?
No, it is germline. So there is no drug involved at that stage. What could be in the germline that without mutation something is ineffective? Suppose, let's say CYP, just make it simple. CYP is the one which is metabolizing a drug, right? And it is present in this level in normal cells, right? And it undergoes some mutation and it doesn't work in another individual, right? What else could go wrong with this thing when it doesn't work? Mutation is one thing. What else could go wrong? It can be degraded somehow, right? And that would make it wrong. Okay, what else? Germline is DNA expression. And how will you regulate expression? Hey, you guys were so good in that particular topic. So epigenetics can dictate whether the protein is made at the first place or it is not made at the first place, right? That is functional genomics, okay? So structural is that the protein itself is changed, and functional is that gene expression, protein abundance, that is changed, and that is often due to epigenetics, okay? All right, so now we know all these techniques. So this is, PGX is part of the story, but we do identification of drug targets, we validate them, we identify disease-associated pathways, okay? Validation, we do CRISPR, we do genomic-guided drug development, personalized medicine, and pharmacogenomics is coming here. You have found the drug and everything, but you have to make sure that you do the testings. Okay, so the benefits are great. Before even you give the drug, you know whether it is going to be toxic or not toxic. You are going to know what dose you should administer, because here there is no room to do trial and error kind of thing, because these drugs are so bad to start with. You cannot afford to give the wrong dose to these patients, okay? So it decreases overall risk for patients. It identifies genetic predispositions to side effects, tailored dose and drug selections for your genome there. Okay, so overview of current and future cancer therapy approaches. So chemotherapy is one fit all approach kind of thing. You just give, like I told you yesterday about that lady who went, she had HER2 positive cancer, they did not test it, they gave her chemotherapy, she died. Okay, so you do tumor biopsy, and sometimes it is shared in the blood also, so you can check it in the blood. You do biomarker analysis, and accordingly you give personalized therapy. You can do actually screening to check whether it is working. So it is also very simple these days that you take a biopsy and you can grow them and you can actually check the drug response also out of those things. Okay. So this is the way. I will show you more details about that. So when you identify a drug, so when in our labs, right, most of the academic labs, we do preclinical research. So we test it in the animal model, we do toxicology in animal model, we do ADME and all these things. Then it goes to phase 1 clinical trial, which have relatively less number of people. Okay. Phase 2 has more, and phase 3 has a lot more number of people. That's the only difference between phase 1, phase 2, phase 3. Okay, and once it crosses all the phases, then there is FDA approval in phase 4, and then it is commercialized. Okay, and then biomarker development also undergoes through the same thing here. So phase 1, screen for potentially prognostic and predictive biomarkers to explore in future phases, consider PGX, and then you just keep going. Okay. All right. So liquid biopsy is also getting very popular now. So it detects circulating tumor DNA in blood. So most of the tumor cells, they shed DNA which is going in the bloodstream, which makes sense because they metastasize, blood gets all the DNA. So this is very non-invasive process. You take it out and you screen for these things there. Like I told you yesterday, sugars are also shed in the bloodstream, and by sugar pattern also one can predict cancer long before it manifests. Okay, so monitoring for emergence of resistance mutations. So tomorrow I will show you that when you give these famous drugs for EGFR receptor thing, they develop resistance. So how do we tackle those resistance? So when you are giving a drug to a cancer patient, you have to closely also monitor how the person is responding and what kind of resistance mutants are emerging. Okay. So, and then AI can always, step in. So the advantage of AI obviously is that humans can see these things at one time. They can look at the entire spectrum at the same time, and they can score it. So if we look at immunohistochemistry images, we see very few things, and they can see every single dot there, right? So they can aid us in real accurate diagnosis. Okay. So this is called polygenic risk scores, or PRS. So AI can aggregate thousands of small genetic effects to predict drug clearance more accurately. Okay, this is becoming quite common now. So key takeaways for PGX: safety first, test for these genes, prevent severe life-threatening toxicity. Somatic testing guides allow us to do target selection, and these are the consortiums. They provide actionable dosing recommendation. If this is absent, this is present, this is effective, this is not effective, they will tell you. And the future is that you do liquid biopsy and use AI to further personalize oncology care. All right, all right. So these two were quick lectures, about 30 slides each. So now let's start the next one. Okay. So it is 11:14. So yeah, let's keep going. Definitely. So, but we will be done by 12:30 for sure. So should we wait for lunch, or? So we'll have 10 minutes break, and then we'll keep going till 1. Is that okay? Okay. अभी आपका बंद है ना? This is a very interesting topic. This is, how many of you have heard of biologics? All of you? Is there anyone who has not heard of biologics? A lot of you, right? Okay. So up until very recently, most of the therapies were small molecule inhibitors, right? So now these biologics are becoming very, very important part of therapy. Okay. So in very simple words, small molecules are the ones which we synthesize in the lab, right? These are small molecules. They are usually small in size, but they can be big in size. But as long as they're synthesized in the lab, even if they're bigger in size, they're still considered small molecules. Okay. So you can build this big of a molecule, okay, with pretty big molecular weight size, it is still small molecule because biologics are really big as compared to these molecules. So look at aspirin, it has 21 atoms. Look at antibody, it has 25,000 atoms. So biologics are extremely big. It's like you are comparing a bike with a, with a huge aeroplane, right? Other definition is that biologics, as the name suggests, they're originating from biological material. They are not chemically synthesized. So they could be DNA, RNA, or it could be that you're making biologics in E. coli or in some organism. Okay, you're producing the protein. Okay, so what is the pros and cons, and so how are these small molecules and biologics important for us, and what are the strengths and the weaknesses of both of these class of compounds? So the goal is simple, that for precision medicine we have to find the right drug for the right patient at the right time. Okay, so let's look at small molecules and biologics. Okay, so small molecules are the traditional backbone of medicine, of course, representing over 90% of the drugs on the market. They are chemically synthesized pills, which we are most familiar with. Biologics are the modern revolution and the fastest growing sector, derived from living organisms. These complex molecules treat diseases previously thought untreatable. Biologics are so important. All the challenges faced by small molecules can be addressed by biologics. How many do you guys know of anyone who is undergoing immunotherapy? Anyone? You guys don't know. That is very good news that you don't know anyone personally who is undergoing immunotherapy. Immunotherapy is all biologics. Okay, the bad thing about biologic, the couple of bad things about biologics is that it is very expensive compared to small molecules. It's very expensive, and the reason why it is very expensive is that because you have to produce it the way they are produced, but more importantly, they can denature very easily, right? So storage and everything is stability is a big issue. So that is why they are very expensive. Okay, but they are extremely useful. So drugs with a low molecular weight, usually less than 900 daltons, but even if it is 2 kilodalton, it is still small molecule inhibitor. Chemically synthesized in lab, stable, defined, predictable. You can make the compound over and over and over and over again anywhere in the world. It's going to be identical. So that's the beauty of chemical synthesis. You can make exactly the same compound no matter where you make in the world, right, with the same purity. But when you make a protein biologic kind of thing, there is always batch to batch variability. You cannot control that. Okay? Not to the extent you can control the chemical synthesis. Okay? Aspirin, statin, kinase inhibitor, Gleevec, they all come under this thing. Biologics are drugs with higher molecular weight, higher than 1,000 to 150,000 daltons. They are manufactured in living systems, bacteria, yeast, mammalian cells, complex heterogeneous folded proteins. I'm going to give you many, many, many examples of that. Okay, so this is just to show you that small molecules usually have 2,200 atoms, and biologics have just enormous number of atoms. Okay, so small molecules usually, not always, they fit in the active site of the enzyme. Okay, so this is the normal enzyme which is binding a cofactor, but small molecule inhibitor will kick this thing out and bind it here. Okay, so it's like a lock and key. Yesterday I was telling you about PROTACs, right? Today I'm going to tell you about PROTACs in great details, and you are going to really love that thing. So what happens is that, like so many times, let's say there is a protein, right? So let's say this is a kinase. Kinase is, like BCR-ABL or any other kinase. So let's talk about some other kinase. Let's talk about Aurora A kinase, right? So this is the active site of Aurora A, and if you inhibit it, Aurora is overexpressed in every known human cancer. So if you inhibit it, you are shutting down Aurora A activity, correct? And so cancer should reverse. So that is one option. But it is also shown recently that Aurora binds with MYC and stabilizes MYC, and it has nothing to do with its catalytic side. It is just binding is stabilizing it. So now even if you inhibit Aurora activity, MYC is still going to be stabilized because Aurora is bound to it, right? And yesterday I told you how bad is MYC, correct? So Aurora inhibition is not as sufficient. So what do you do now? You make Aurora disappear completely. You degrade Aurora, and PROTACs is a wonderful tool to degrade the protein completely. So protein is made, and you just degrade it at your will. Okay, and this method was developed by Craig Cruz in early 2000, and it rose so rapidly that there are many, many, many PROTACs in clinical trials right now. Okay, so detailed mechanism later, but this is your protein of interest. And also there is another thing why PROTACs are very useful. So kinases, they at least have an active site, and you can make a small molecular inhibitor for it. But there are many proteins which have no active site, like MYC. How do you make a small molecule which has no hole or something where anything can fit? These are undruggable targets. Degradation works for them equally well, right? So the best part of PROTAC is also that any undruggable thing can be degraded, right? So this is a protein of interest which is considered undruggable because there's no pocket for small molecular degrader. So you make another thing, small molecular degrader or PROTAC, okay? So how many of you have heard of ubiquitination? Is there anyone who has not heard of ubiquitination? You have not. So ubiquitination was discovered, I think, in 1990s. And so what it does, it was, those people got Nobel Prize. So they were asked to explain their research in layman's terms so that the rest of the world could understand. So they said it is the kiss of a death. So if this is a protein, and you ubiquitinate it, then this is like tagged for degradation. So if you put a ubiquitin group, then will go to the proteasome. Proteasome will recognize the tag, and basically it will be degraded, and all the amino acids will be recycled, right? So that time this was correct, but ubiquitination also, there are of many varieties, so there are different things, will not go there, will stick with classical ubiquitination. So basically if you put the ubiquitin, then it will be degraded. Is a tag. It is, ubiquitin is a very small protein, and it's like 72 mer or something, and you put first ubiquitin and then the second ubiquitin and the third and the fourth and the fifth and the sixth and the seventh, small chain, and proteasome will recognize it, eat up. And proteasome is like a barrel. The protein will go inside, and here the chopped pieces will come out. It has a lot of those inside. You use proteasome inhibitors, you have to use that. Yeah. So this is in very simple terms. What is this thing, right? So there are these enzymes called ubiquitin ligases which tag the protein. So there are three of them, E1, E2, E3, and they are called ubiquitination machinery is brought up. So basically what you do that, so you don't even need to attach ubiquitin. So idea is very simple. Let's say this is a protein I want to degrade, and this is E1, E2, E3 proteins. So if I even bring them in close proximity, it will get, because they will put ubiquitin there, and this will be tagged for degradation, right? So what you do is that you make a small molecule which will bind this protein of interest. It has to have a pocket for that, right? So it will bind that protein of interest, and the other part will bind this E1, E2, E3, one of them. And then it will come close to that, and then it will degrade it. Is it making sense? Right? So this is what is shown here, this small molecule degrader. This is ubiquitin ligase, which is bound to E2 and E3. So usually what you do is that you make a compound which binds your protein of interest at E3 ligase, not E1 or E2. E3, they are all together. So then you bring them in close contact, and E2 will put the ubiquitin thing, and it gets degraded. Okay, so it is not making sense. I have complete like structures and everything, but basically you tag the protein for degradation. So what happens is that if ubiquitin is added, it will be eventually degraded. Ubiquitin is added by E1, E2, E3 enzymes. There are 3 different enzymes altogether. So if you bring E1, E2, E3 next to the protein of interest, ubiquitin will be added, and this will be degraded by proteasome. Okay. So how do you bring these two guys together? You make a bifunctional compound. On one end, it's binding your protein of interest. The other one is binding the E1, E2, E3 complex, particularly E3. Is it making sense? And that's how it is degraded. Okay. So let's look at the success story of Gleevec. Okay. So keep in mind, we are in the small molecule arena here. So we will talk about both simple small molecules and PROTACs later on. Okay. So this is just a simple molecule. Gleevec binds in the active site, and we know how successful that was, right? So what is the advantage of small molecules? The pros: it is orally bioavailable. You just take a pill, it works. It can, because it is a small molecule, it can penetrate deep in the tissue, right? So no matter how big is the tumor, it will go all the way inside. It is usually very cheap. You know, Gleevec, when it came out, it was very expensive. I don't know how expensive, but I'm guessing it was very, very, very expensive. It is not that making the compound is expensive, because probably we can make it in less than whatever, 5,000 rupees, right? But the drug would be 50,000 rupees, because billions of dollars were spent in identifying that. So they have to get that money back. And that is why the drug cost is so high initially, till it becomes generic, and then everyone can synthesize it. But they are still very cheap. Okay. Then they usually cross the blood-brain barrier. So if somebody has brain cancer, it will cross the blood-brain barrier and it will reach there. So these are all the advantages, but they also have a lot of disadvantages. The biggest disadvantages are, because these molecules are simple, they often have side effects. They often have cross-reactivity. So it's usually very hard to make a monospecific inhibitor which will only inhibit one target. It will inhibit multiple targets. They also have short half-life because they are so small. They are just metabolized and cleared quickly by the body. So you have to take daily, sometimes 3 times a day, like we take antibiotics 3 times a day, right? When someone is given immunotherapy, they give you once in 3 weeks or once in a month. It stays that long. Okay, but antibiotics, how many times we have to take for 10 days? 30 times, right? 3 times a day for 10 days. Okay, so I included this because this is something I was telling you guys, and I said SETSA something. SETSA is a thermal assay. It is ISA actually, but it is a small molecule thing, so I had to show you guys what this is. This is the one, remember I was telling you, you open up the whole brickload of assembly and you kill the cancer cells. This is what it is, ISA. Okay, but this is small molecule. So what you do is that you take small molecules selectively to target cancer cells, and then some enzymes will make a supramolecule thing. So you add small molecules, and cancer cells express this alkaline phosphatase. So all of these small molecules will accumulate there, and they will form a supramolecular structure there. Okay, once they make that structure, now the cancer cells, on top of cancer cells, the whole assembly will disassemble. So it's like you take a truck load of bricks, and it will go to cancer cells, and it just throws all the things right there. and then it will kill that. And once it kills them, all the tumor antigens will be out, and the immune response will also be triggered to clean it up. So why I am so excited about this approach? Because this is like physically going there and killing everything at once. Like cancer cells should not have time to respond, because then they will develop resistance. So you have to just use a magic shotgun so fast, kill everything quickly enough. Okay, now let's come to biologics. So biologics have to be vaccines. Vaccines are produced cells, tissues, recombinant proteins, DNA or RNA. Okay, so what is the key characteristic? Large molecules like enzymes, uh, cytokines, antibodies. They're produced in living organisms, bacteria, yeast. So next Saturday, I will have an exam for you guys. Okay, you have to pass the exams before you are officially what?
Given the certificate.
Given the certificate. Huh? Grade sheet is there too. So please pay attention to everything I am telling you, because I'm going to ask you this thing. Tell me whether this is a biologic or not a biologic. So pay attention to details here. Okay. They are highly specific. That's the beauty of biologics, right? They're very specific, bigger structure. They have so many things to have this thing. But they are not given orally, because if you give it orally, our digestive system will completely digest the whole thing. So they are given intravenously, okay, which is the bad thing. Okay, so examples are monoclonal antibodies like Herceptin, cell-based like CAR-T therapy, vaccines, recombinant insulin, right? Insulin is a recombinant protein. Erythropoietin is given for anemia. Okay, erythropoietin is given for anemia. Now this is an interesting slide here. So look at this thing. So these dark ones here, this dark blue ones, they are small molecules approved by FDA in 1997. Antibody-based is red, and non-antibody biologics approved by FDA is in green, and CAR-T is in orange. So now look at, since 1997, only 2 antibodies were approved and 5 antibody-based non-antibody-based biologics. Then 98, 5 antibodies, 99, no antibody. But look at the red and the green, barely anything. Okay, no CAR-T, no CAR-T. Now here, for the first time in 2017, CAR-T was shown up. And look slowly how many monoclonal antibodies, all the antibodies and non-antibodies are being approved now. And PD-L1 and PD-1 is among these ones. So it's a very recent discovery, very, very recent discovery. Okay, so biologics market right now, it is 349 or 25, we don't even know. In 23 it was 349.6 billion. Okay, and it is estimated to really rise very rapidly. So this is becoming a very, very hot emerging field. So one of the disadvantages of biologics, especially with monoclonal antibodies, are that they're so big they cannot cross the cell membrane. So specifically, if you are using monoclonal antibodies, you have to target those things which are expressed at the cell surface, like EGFR receptors, right? So receptor-based drugs, you can easily use antibodies because they don't have to cross the cell membrane. They just have to bind something outside the cell. So this is antibody structure here. So these antibodies are too large to enter the cells. So if the receptors are outside the cell, the antibodies will bind. Antibodies are Y-shaped, you guys know that, right? Okay. So they act like magic bullets, locking into the specific markers on cancer and immune cells. So on one side, they will bind cancer cells, on one side, they will bind immune cells, and they will bring together because their hands are like this. So if they're binding both, they have to be together, and immune cell will kill the cancer cell. Okay, so these are some of the classes of biologics. Okay, so I wanted to tell you, yesterday you asked me about oncolytic virus, right? So number 2, I had something else. So I replaced it with oncolytic virus. So I thought I should, but then I'll talk about this again in the third lecture. In the third lecture today. Okay, But keep in mind, this is not all. This is just few classes of them. There are many other classes also. So let's start with monoclonal antibodies. So these are lab-made antibodies that target specific antigens which are present on cancer cells. Okay. So again, HER2 is coming up. HER2, so HER2 receptor is overexpressed. So if you make an antibody, it binds there, it inhibits the signaling pathway. How many of you have heard of Humira? Has anyone heard of Humira? Have you heard, Venkatesh? Humira? This one. Yeah, because I have heard of it because the advertisement is always coming there for Humira, but I did not know what exactly it was at that time. Humira is also an antibody against rheumatoid arthritis. Okay, so this is a monoclonal antibody. So this is the monoclonal antibody which is specific for specific receptors. And once this bind, two things happens. First of all, if you bind it to the receptor can no longer send the signal downstream. That is one thing. Second thing, what happens when antibody binds, the immune system gets activated and immune cells come near that and immune cells will eat up the tumor cells. So it also elicits an immune response. So this is a, it has dual benefit here. Okay, so there are many kinds of antibodies, like they can bring two things together. They bind one thing, one tumor cell from one side, immune cells from this thing, and immune cells are in proximity, they will kill the tumor cells. They can directly bind tumor cells. They can act as cofactor, bind it, but then not let the signal go in. Okay, they can also bind to something and get inside the cell through endocytosis. They can piggyback and do. So there are many kind of different antibodies there. Okay, so we tell the story of the famous Herceptin. The trade name for this is trastuzumab. MAB, you know what MAB means? Whenever you see MAB, MAB is M is monoclonal, AB is antibody. It means it is a monoclonal antibody. Anytime you see MAB in the end, you know it is a monoclonal antibody. Okay, so this is the cartoon for layman, and then I will show you the actual thing which is happening. So basically, HER2 is overexpressed in breast cancer cell lines, and HER2 leads to cell proliferation uncontrolled, but it also promotes angiogenesis. That's why shutting it down is so important. So under normal circumstances, cells grow and there is angiogenesis, but when Herceptin binds, all the pathways are shut down, including angiogenesis, and the tumor cells die. And this one is actually showing you what is happening with Herceptin. So this is HER2 receptor. So this Herceptin binds here to the receptor. So once it binds, see how it is binding. So normal case, it will bind like this. Two things will come very close to each other, and this kinase domain will phosphorylate this, and this kinase domain will phosphorylate this. So these are the phosphorylation. So they will phosphorylate, cross-phosphorylate, right? And then they will get activated and the signal will turn on. Now this binds it like this. So this is non-productive binding. They cannot phosphorylate. So basically they are logged in inactive conformation, and antibody binding is extremely tight, very tight. You cannot get rid of them. Once they bind, they bind. Okay, then once they bind, now the receptor is endocytosis. So once again, let me tell you that. So when you're cooking something in the kitchen, you smell it, right? And then the smell goes away after some time. Okay, and then if you leave the kitchen, go away for some time and come back, then you can smell it again. So why does the smell go away? So normal cases, we have receptors. So we are smelling. After a while, when the receptors get engaged, this is the biological phenomena that receptors will be endocyzed. So all the receptors will go inside, and then they will come and they will be recycled again. So if they are not coming back, if they are still inside, we cannot smell. Only when they are recycled back and they are up there, then we can start smelling it again, right? So if they get engaged, it is endocytosis there, okay? And then in some cases, it will just bring the immune cell also together. Okay, so there are many ways. So what is the pros? It is extremely specific. It can target undruggable targets. You can make antibody towards anything, which is even if something is straight, no pocket, you can make an antibody. Antibody will just recognize any surface, and you can make a very tight binder. Okay, and many biologics, when antibody binds, it brings the immune cells. You are activating the immune cells too. Okay, the bad thing is that it is not an oral pill that you can take, so it has to be given intravenously. Usually, if it is like a cancer immunotherapy, you have to go to the special facilities and they will administer it. Okay, it is very high cost and it is pretty complex. It requires refrigeration and things like that. Okay, and once you, and then also sometimes when you are giving the antibody and it is circulating in your bloodstream, your immune system can get really activated and start attacking without the antibody reaching the target. So you can have a severe immune reaction also there. Okay, so now let's go to oncolytic virus. So oncolytic viruses selectively infect and lyse cancer cells while activating an anti-tumor immune response. So what you do is that in another lecture, I have a more detailed slide on oncolytic virus, which will show you 3 ways oncolytic viruses kill cancer cells. Go ahead. Oh, you have to speak. Please give that.
Hello.
Hmm.
Actually, ma'am, the tumor is covered with the fibrous tissue, and the tumor microenvironment is very complex.
Yeah.
So, does the monoclonal antibody have the power to like invade inside the tumor? Because
Yeah, so here is the thing, not all tumors are equally fibrous here. So like pancreatic tumor is actually, the tumor is this big and the fibrous thing is this big. This is actually true. The tumor is this whole thing. So any drug will be very hard to get into the pancreatic thing. Breast tumors are not like that. There is a microenvironment there, but these antibodies can get through that. And also the advantage is that it is poking out of the cell there. So it is very much there and it is turning on the signal. So it's a very active component. Antibody can access it. Yeah. Okay. So oncolytic virus here. So first thing is that you make an oncolytic. So what is the problem of the viruses? If someone is infected by the virus, they divide. Yeah, go ahead. Oh, you have to use that.
so, ma'am, can we say that the monoclonal antibodies will stay for a longer time if even if curing the disease, like in the bloodstream, they will stay for longer period?
They do stay for a longer period of time because I know personally of someone who is undergoing immunotherapy right now, and he's giving PD-L1 and VEGF inhibitor antibodies every 3 weeks. So it is staying in his body. So, but if you take a small molecule inhibitor, liver cleans it up very quickly. So oftentimes, many diseases we take 2-3 times a day. At the very least, we take once a day, right? So yeah, they stay in the blood for a long time. And also, so yeah, your question is very valid. In interest of time, I'm not telling you a lot of things, right? So what we do so that it is recognized as self. So we make these antibodies humanized. So they resemble our antibodies. So initially when the research was going in this direction, you cannot make antibodies in human to inject it in humans, right? You obviously cannot use human as controls. Like you cannot use humans to generate antibodies for someone else. The human will die. So we were generating in mouse and rabbit and things like that, right? But as we were sequencing and isolating human antibodies, we know exactly how human antibodies look. So now you can recombinantly make antibodies in your lab. Okay, so they are vectors which will encode for heavy chain and light chain together. And if you put that in E. coli, it will make the human antibody for you. So these are humanized antibodies. So they are not recognized as foreign by the immune system. So we know exactly which is going to trigger the immune system, and that is the part we change it to make it more self-like. So that's why they can stay for that long. But this is a very relevant question. Okay? All right. Go ahead. Please say, yeah. Thank you.
When we are synthesizing the small molecules, we are told that they should obey the Limbisky's rule of 5. So,
What effect?
when synthesizing or designing small molecules, we are told that they should obey the Limbisky's rule of 5.
Oh, yeah,
So
the rule of
for
5.
peptides, biologic small peptides, is there a rule like that?
There are no rules because they vary from one end to the other end, right? So the rules are very different than what it is for small molecules. Okay, so when we are saying that they have to follow Lipinski rule and all of these rules, right? But PROTACs don't follow those rules. PROTACs are much, much bigger than that, but they are still very effective. So if you follow those rules for small molecules, the chances improve. But as you go more and more complex, you do different things to make them there. Antibodies can trigger a huge immune response. So we have tricked the immune system to recognizing them as self. So there is no general rule like we have it for small molecules, because the diversity is infinite there. Plus, think of it, it is not made by chemical method, it's made by the organism. It depends on organism's health. Every batch is different, you know? All right, so we are back to oncolytic virus. So what is the disadvantage of virus? Virus will go, and if it infects any cell, it will just divide it within that cell and make more virus. And because it has made more virus, the cell will rupture and more virus will be released. And then they will infect the neighboring cells and make the virus, and those cells will rupture and they will release more virus. So they're very, very toxic, right? So when these oncolytic viruses are made, they are made in such a way that they cannot replicate in normal cells. They can only replicate in tumor cells. So they go and infect tumor cells, replicate there, and kill the tumor cells. So just by being there, they kill the tumor cells. But then you can also add some toxin to the viruses so that when they replicate, the toxin part is released, and that further kills the tumor cells. So there are 3 ways they can kill. I'll tell you about that later on. The third part is that when tumor cells are killed, right, ruptured, then the tumor antigens will be exposed. Immune system will get activated. Immune system cells will come and kill it. Okay, so that's what it is. So infection of tumor cells, viral replication, tumor cells lyse, release of tumor antigens, immune cells get activated, you clean up the mess. Okay. Okay. The third thing is vaccine. Okay. So we know vaccine for many different things. We are using for cancer also. Okay, COVID-19 vaccine is not cancer vaccine, but we know about it. So what is a vaccine? Basically, you take dead tumor cells, you irradiate it so that the antigens are just there, but they are not enough to cause cancer because they're all dead, right? And then you inject them, the body has a strong immune response. Antibodies are made, right? And then those antibodies will go and recognize the tumor cells. They will destroy it. That's the vaccine thing there, right? So this is what it is, that tumor cells you take, you kill them, you take the component, you add it, and now the body does the rest of the things. This is just to show the mRNA vaccine for COVID. So we were discussing it a few days ago, the pros and cons of mRNA vaccine. The biggest pro was it was very quick. It was very quick. Okay, because otherwise it takes many, many years. But you know, it was forced upon us to develop it very quickly. Okay. All right. Gene therapy, I'll go a little bit fast because I have one whole lecture after this devoted on gene therapy, entirely on gene therapy, because it is such an important topic. So here I'll introduce you, and then in that lecture I'll tell you, just like for 1 hour we'll just discuss gene therapy. So some of you were also asking me about gene therapy. So now with the advent of CRISPR-Cas9, cystic fibrosis can be treated. You just fix the gene. Okay, you fix the gene and it is done. Okay, so Any of you have done transfection here or infection in the lab? Probably not, right? Okay, so there are, when you deliver the DNA in the cells, that process is called transfection, but that is transient. But if you take the DNA and package it in a virus and infect the cell, it gets integrated in the cell DNA and it is there forever. Okay, so usually when we deliver DNA to human bodies, it is packaged in viral vectors. So these viral vectors are harmless vectors. They are just delivery vehicles for the DNA. So the principle is that you deliver the DNA and the DNA will make the therapeutic protein. Okay, so there are many different kinds of gene therapy, and like I said, that is the whole one lecture devoted to that. So we'll go through each of these things in great details in the next one. Now let's come to cell therapy. These are all biologics. So CAR T therapy comes under cell therapy. So it involves the transfer of intact live cells into the patient, stem cell therapy, CAR T cell therapy. Okay, so what are the processes? So today I'll tell you about CAR T, but then I have a whole lecture, actually 2 lectures devoted to immunotherapy, and there I will show you the structure of CAR T therapy in details. Okay, so you will keep hearing about CAR T in many lectures, but those 2 lectures are just extensively on CAR T therapy. Okay, so I want to tell you a little bit about what is the meaning of autologous and allogenic patients. Okay, so suppose you want to take the cells and correct it in a patient. You have 2 choices. So let's say this patient has some problem in some DNA. So first choice is that you take out the cells from the patient itself, right? And then you grow it in a plate and you fix it. And once you fix it, you inject it back, right? So that is autologous. Okay, the advantage is that it is the same cell. It's patient cells going back, immune system is not going to get activated. So this will be no immune rejection. So that's the good news there. The bad news is there the patient itself is in a bad situation and you're taking cells out of that patient, and then we have to wait till it is fixed, right? And the patient may not have that long to live by the time we make the whole thing. It may take months to get it back in the patient. So it would be ideal that we have something made in the shelf and we just inject it in any patient without the fear of immune rejection, right? So we have to do something, because if we just put it from, so we take out cells from healthy patient, we engineer it, keep it in the shelf, and we give it to the whole population, they are likely to have a rejection thing. So we have to fix something in this. So we'll talk about this briefly. So here, for example, so this is allogenic. Allogenic means that you're taking from healthy patient and then giving it to the healthy people, and then giving it to different individuals. Okay, so normally you take it out from the, whether a healthy person or the and then you or the patient, then you engineer it, you make special cells, then you put it back to the patient, and then then it does its magic and cancer disappears. So what is the principle? You remove the cells from the patient or from a donor, then you increase, you cannot take out a lot of cells, you have to grow them, you have to make them in a large population, then you purify it, then you make the genetically engineered cell line, and then you put it back in the patient. Make sense? Okay, so when we do stem cell therapy, that is how we do it. Okay, so stem cells are those that they will make more stem cells, but they always have the capability to differentiate into any kind of cells. So suppose somebody undergoes cancer therapy, right? And we do irradiation, so the organ is damaged. So we do stem cell therapy to repair that damage. Okay, so all right, cytokines. So when you do, these are cytokines are those proteins that modulate immune response, like cancer and autoimmune diseases. So let's see that. What we do, this is a really untreated cancer. Look at the blood vessels, very bad situation. So now we add a cytokine which is interferon alpha. So interferon alpha comes in, it suppresses angiogenesis and it promotes cancer death. So if you have to make interferon, you have to make it in bacteria, right? So it is a biologic, okay? So these are cytokines here. Now fusion proteins, this is an FDA approved drug. So this drug is called Embrel or entanercept. So this is TNF receptors fused with this IgG part here. Okay, so this TNF R receptor, this binds TNF alpha with high affinity, and this fusion part, this IgG Fc region increases stability and serum half-life. So you were asking me how long the antibodies are going to stay in the bloodstream, right? So this part actually increases the stability. So what happens is that uh, this is given in rheumatoid arthritis. So in rheumatoid arthritis, TNF alpha levels are very high, and TNF alpha activates inflammation signaling pathways. Okay, so it leads to inflammation. So what you're doing, you're giving this receptor, and receptor is souping up all TNF alpha. So it cannot bind to the receptor, and inflammation signaling pathways is shut down. Is it making sense? You're basically sequestering all the TNF alpha from there. So this is a fusion protein there. Okay, this is another example. So you are giving a fusion protein attached to an antibody, and this is an enzyme. So there is an antigen on the tumor cell. Pay attention. So tumor cells have something special which is not present in normal cells. So you make an antibody, and antibody will attach there because, and antibody will only attach to tumor cells because only tumor cells have those receptors, right? But the antibody itself is bound to an enzyme. Okay. Now you give a prodrug. Do you know what is a prodrug? You know prodrug, right? So it is like a masked drug. It is not complete unless the pro part is released. So now prodrug is circulating in the rest of the body, nothing happens. But when it reaches the tumor cell, because of this enzyme, prodrug is now releasing active drug in the close proximity of the tumor. So the tumor cells can get the actual drug, but nowhere else the drug will be produced because the enzyme is missing. So the tumor cells die, right? So this is another example. Hormones, okay? So for example, breast cancer, right? Breast cancer feeds on estrogen signaling. So if you give so estrogen promotes signaling, but tamoxifen looks like estrogen, but it inhibits signaling. So if you give tamoxifen happens to be a small molecule, but if you can give hormone which mimics that actual hormonal structure, then it can inhibit it. So you can use biologics to inhibit hormonal signaling if it is toxic, right? That's what is shown here. So blocking hormone receptors like estrogen receptors, suppressing hormone productions, surgical hormone suppression. Okay, so this is basically hormone therapy. This is also a biologic. Okay, do you guys know what is the meaning of adjuvant, neoadjuvant, and palliative? Anyone? Say that again. That's okay. Just let me ask you, what is palliative therapy?
To reduce the symptom, not actually curing the disease.
That is what is palliative. So palliative is the last resort. You cannot cure the disease, but you're reducing the symptom to just have a better quality of life. That is palliative. Like we have given up, we are just making the person comfortable, right? What is adjuvant? Adjuvant is a therapy which is given after the main treatment, like somebody is undergoing surgery and you give chemotherapy after that, just to make sure if there are any lingering cells, they die. That is adjuvant. But if you give it before that, then it becomes neoadjuvant, right? That is the meaning of it. So coming back to hormones, if you are inhibiting hormone signaling, hormone receptors, you will give hormone mimics there, okay? This is, see, estrogen is written as OESTRON. I think this is British way of writing it. So estrogen will start the signaling, tamoxifen will inhibit the signaling. Okay. Then let's go to enzyme replacement therapy. This is the last biologic. So enzyme replacement therapy treats genetic disorders, especially lysosomal storage diseases. So in many cases, if I have to ask you define the function of lysosome, what would you say? What is the function of lysosomes?
Nice, all the cells come into the target cell.
No.
Immune cells.
No. Lysosome is an organelle in the cell.
Achha, okay, they have back it have hydrolytic enzymes.
What is it? So I tell my student it is a trash can of the cell, which has to get rid of all the trash, right? So, but the lysosome has very acidic pH because they have to degrade it. If the lysosome is not functional, they will collect all the garbage and they will become bigger and bigger and bigger and bigger, and the lysosome size will become bigger and the whole cell will be in very bad state. Imagine if the trash is not cleaned up, we will get infected with all sorts of diseases. So it's a very serious disease when lysosomes are not functioning properly. It is a genetic disorder, right? So there we do enzyme replacement therapy. So this is a really nice one. So we give the functional enzyme. So we are not fixing the enzyme which is wrong. We are giving the functional active enzyme intravenously. The enzyme enters the bloodstream and it reaches to the lysosome, the cell's recycling center. Okay, and then once it is there, it cleans up all the mess because the right enzyme is there, and the lysosome structure, which was so swollen, becomes the normal size. Okay, so now you are basically not changing the thing, you are just replacing with the new enzyme. That is enzyme replacement enzyme, accumulated substrate, it undergoes, and then your restoration of normal cell functions. Okay, now now you have looked at biologics and you have looked at small molecules, right? So small molecules are much easier to synthesize. They are much cheaper to do that. Manufacturing, it is like growing, biologics is like growing a rare plant. It uses live cells. They are sensitive to temperature, pH, high variability. Having said that, it is becoming very common these days. It is, but this is a very important slide, although it is written very small in here. So I'm comparing biologics versus small molecule drugs in precision medicine. These are large biologics, these are small. Biologics are extremely specific towards their target. Small molecules have off-target effects. Mechanism of action, they can block receptor interaction, they can inhibit protein-protein interaction, they can turn on an immune signaling, they can kill the cells. They're usually inhibited. They bind in the pocket and inhibit the enzyme active site. They are injected by IV. These can be oral. Oftentimes it is oral. Patient family. Onset of action, if you take a drug, small molecule, it has a very fast reaction. This takes some time to build up and then it works, but it is longer lasting, weeks and months after dosing. Like I said, for immunotherapy, I know this person is taking every 3 weeks. This is, here we need to take daily. This is very costly, this is very cheap. There is a, unless you humanize the biologic, it can have an immune reaction. Okay, now this one, small molecule resistance are much easier to develop. Okay, so resistance develops by secondary mutations or efflux marks. In this case, tumors also become resistant to immunotherapy and other therapies like with biologic, but it is a little bit harder to develop resistance. Very expensive. This is a lot cheaper, and you know the examples already. Okay. So mechanism of resistance for small molecule is that, you know, if the small molecule is designed towards this pocket, the mutations will occur in this pocket so that they don't have to bind this molecule anymore. Okay, and in this case what they do, If it is binding the receptor will change its structure or it will not even show up those things. So wherever it is binding, those things will change so that it no longer binds. Just see how smart cells are. They just keep changing because they don't like to bind it. Okay, so now I'm going to show you one compound which combines the beauty of both small molecules and biologics, and that is ADC. ADCs are ADB drug, antibody drug conjugate. So it is a biologic plus a small molecule. So you are giving a monoclonal antibody, but you're attaching real toxic molecules to it. So now the antibody goes and binds there, it is internalized, the toxic molecule is delivered inside the tumor and it will kill it. That is ADC. Okay. So how ADC works? They are bind, they are internalized, they are released inside the cell, causing cell death. Okay. And this is bispecific. So bispecifics are bispecific T cell engagers. So on one end, they will bind the cancer cell. On the other end, they will bind the T cell. And when you bring the police right next to the thief, something has to happen there, right? Immune cell can ignore it from a distance, but when they are together, tumor cells will die. Okay, so this is, look at this thing. So they have made this here. So there are many kinds of bispecific antibody. So this is one part. Now they have chemically combined it to bind a different one. You guys know when you have antibody, this is the part which recognizes that, right? So if I am Y-shaped, this part is recognizing the antigen. So this part is recognizing a tumor, this part is recognizing immune cells. Okay, so pay attention to this, just the blue part and the red part. Rest, everything is the same. So this recognizes tumor cells, this one is recognizing the immune cells. Okay, and you can actually couple them together chemically. Okay, so, and we have many variations of that. We can attach radioactivity, we can attach similar drug, we can attach dual drug. See, this is a bispecific antibody, this is just a regular antibody with two different drugs. So we have huge combination. We can attach fluorescent reagent, we can, so that we can see where it is going. We can attach the drug and the fluorescent molecule, right? So there are many ways to do that. And today I'm also going to show you that the antibody themselves can be changed. Okay, so what is the biggest disadvantage of antibodies that you say? It's very big. So now we can make really tiny antibodies which work really well. Okay, now have you ever heard of biosimilars? Never heard of it. This is a very new word. So these biologics are very expensive, right? So biosimilars are also biologics, but they are less expensive, and they are similar, but they are not identical, and they're easier to make. So these biosimilars, when patents for major biologics expire, biosimilars are entering the market. They're highly similar copies that offer comparable efficiency at a reduced cost. Do you guys know about the patent and the generic drugs? Do you all know that? Is there anyone who has not heard of generic drugs? You haven't. So what happens is that when you make a drug, right? So with extremely few exceptions, it takes years and years and years and years of work to find a drug, especially for disease like cancer. Okay, so and hundreds and hundreds and thousands of people work, right? So you spend billions of dollars before you can find that one drug, right? But once you find the drug, it may be a piece of cake to synthesize it. So then everyone will start synthesizing it, but the company who made that thing is not going to get the money back. So in that case, no company will ever spend the time in developing a drug, because the moment they develop a drug, everyone is synthesizing it. So they apply for a patent. So that patent restricts the rest of the world, the whole world, to synthesize that compound, so that everyone has to buy from them. Okay? But once the patent expires, which is, I don't know, 10 years? 20 years. 20 years. Then the generic versions come, and then other people can synthesize it. And they can also modify it here and there. It depends on what the patent has used for protection, right? So then there are the generic versions, okay, that can have different formulation and this and that, basically the same drug, and they are at a very reduced cost. So for example, if you take thyroid medication, right, the I can't even remember what is the name of the non-generic one, the actual one. Synthroid. Synthroid is the thyroid medication, but the generic one is called levothyroxine. So if you buy levothyroxine, it is dirt cheap. If you buy Synthroid, it is very expensive. But once the generic one comes, nobody ever will go for Synthroid because it's the same chemical, correct? So it is the same for biologics. So once the patent expires, then similar structures are produced. Suppose they, yeah, it is almost similar, but it is much cheaper to produce. Okay, is it making sense? Okay, so that's what it is. So this is just a new term which has just originated. It is highly similar version of an approved biological product, nearly identical structure, but may have slight natural variation, made after original patent expires. It is a generic version of small molecule drugs. Okay, and this is 15 to 13%, 30% less expensive. So one day, what do we want? That the biologics can also be taken in such a way that we don't have to go through intravenous injections. Okay, and because you go to the hospital to get it, it becomes super expensive. All right, and of course, AI, we need the help of AI in accelerated drug discovery. Okay, because these things can predict protein structures and identify hidden pockets for drug binding. All right, all right. So we have to synergize between biologics and small molecules. Synergy is the key here. All right, this is the end of the story. Didn't feel like 60 slides, right? Okay, so what we will do, we'll take how many minutes break? 10 minutes break. So it's 12:12. So 12:22, 12:20. If we come at 12:20, we can actually finish it by 1:05. Then we will, it is much better, just be here sharp at 12:20 so that we finish it before lunch. Then we just have tutorial left. And from Monday onwards, we'll have 3 lectures. So it will, I have a suggestion, I have a question to ask you guys, and it's entirely dependent on you. So today we'll finish 15 lectures and 15 are left. So if you wish, we can continue with 4 lectures and you guys can have Christmas Day off, if you prefer that. And otherwise, we'll go with 3 lectures. I am good because 4 lectures is nothing for me. You can celebrate Christmas. So raise your hand if you're you want 4 lectures so that we can have the Christmas Day off. All right, me too. Okay, both hands. Okay, so we'll continue with the 4 lectures so that we can have the Christmas Day off. You guys can enjoy. All right. So, so if you want to break, just 12:20 back. Go ahead. You have to. वो ऑफ है क्या? हाँ, तो ऐसे ही बात कर सकते हैं. हाँ. Yeah.
Is that an example of a biosimilar, or is it an invention?
It cannot be biosimilar. You know why? Because Professor Venkatesh was saying it is 20 years and the first CAR-T came in 2017. So nobody can do that. So they are doing on their own, like different thing.
Okay, so different mechanism.
Different target for this thing. They cannot make biosimilar right now. Yeah. We can possibly make it for monoclonal antibodies, right? But we cannot make it for CAR-T because it's not even there.
Can biosimilars also be a reason for health disparities?
No. So biosimilar will be approved only if they work equally well or better than the original. Health disparity is different thing. Health disparity is that first that the clinical trials are highly biased because they include all the people like who are white. For example, in Western countries, they do not include people who are in minorities. Partly it is because they have never thought about it. It may not be intentional. Second thing is that health disparity arises because minority people are very poor. They do not, they live in a bad places, and since they are not included, they are afraid to go and get tested. They don't have money. So that creates health disparity, and then people blame it. Oh, they get aggressive disease because it is in their genes. It is not in their genes because they are living next to highway, industrial waste. So they are constantly exposed. So all of these things, they live close to places where there is not enough healthy food. They don't have access to greenery. They don't get fresh air. They don't get fresh water. That's where health disparity is coming. So it has nothing to do with this discovery. Yeah. Makes sense? All right. So what are you going to do during Christmas? Just take it easy, right?
I want to sleep. I want to sleep that day.
Of course, of course. When I get a break, I don't want to go anywhere. I just want to catch up, you know?
You're from IIT Kanpur.
Yes.
Okay, you reside there, or you're originally from Kanpur? Or?
I was from Kanpur, but that makes no difference, right? For IITs, it makes no difference. Yeah. But I was from Kanpur. Yeah. Uh, I don't know. I was looking there thinking it is a clock. I work on cancer and Alzheimer's disease. Yeah, I have PhD students, I have postdocs, I have undergraduates. So yeah, they're working on those things. So in my lab, it is more about knowing cell biology very well. I also have chemists for making drugs because I also have chemistry background. So, but more of the biology background. So if the person is well versed in cell culture and transfection and all of those things, like microscopy, Western blotting, QRT-PCR, these kind of things. Biochemistry, yeah.
In Delhi. So I was practitioner of cancer biology. So I was targeting to signaling pathways.
Very nice. You are the one who is having problem with the cells. Who was her? Yeah, she asked me about the cell thing, right? Yeah. You should have been trained there. Like, this is the first thing you should have been told. You would not know that the cells cannot go. This is the first thing you have to tell a student. Don't let the conference go that much. You guys are also becoming, pretty resilient, listening to lecture after lecture after lecture. Wow. Yesterday I was having a really hard time because I could not figure out that how the lecture number is 11. I could have sworn I taught 4 lectures, and then I thought, and Venkatesh kept asking me, so you have taught the fourth lecture? I said, yes. He asked me again, and then he asked me again, and then I realized I only taught 3 lectures actually because it is not 12. And I have no recollection I taught 3 lectures on the first day. Okay.
You didn't take those 10 minutes break, no? So how few minutes ago you break?
Yeah,
You were in a flow.
in a flow, yeah. All right, let's get started so that we can have lunch at 1. So today we have covered for that. Today we will cover for that missed day, and then and we teach 3 lectures. We are supposed to. I am supposed to teach 3 lectures per day. So which day is Christmas Day? No, it is 25th. Which day? It cannot change. आप रिकॉर्डिंग तो नहीं कर रहे ना, अच्छी बात है, ये बात तो जानी भी नहीं चाहिए. अभी चालू मत कीजिएगा 1 सेकंड के लिए. Thursday. So Monday, Tuesday, Wednesday will have 4 so 25th is free for us. And then Friday will be the last class, and then Saturday you guys will have, exam, and then I don't want to think about Tata bye bye. I'm having too much fun here. Okay, so let's talk about gene therapy in details now. Okay, so this is like a broken gene. This was something which was like it was supposed to be so hard, and it is becoming a piece of cake these days to do gene therapy. Something is missing, you just replace it. Okay, so if something is missing, you replace it, you add it. If something is broken, you fix it. Okay, if something needs to be deleted, you delete it. Everything is possible. Okay, so so let's look at, you can add an anti-angiogenic gene. You can stop angiogenesis for cancer. Okay, you can add suicide gene therapy. This is really interesting, suicide gene therapy. It is really interesting. CAR T cell therapy, immunotherapy, you can activate tumor suppressors. P53 is missing, add P53. P53 is defective, correct it, add it back. Okay, you can inhibit oncogene activation. Okay, so these are so many things you can do. You can do genome editing. You can. I taught a Gyan course in 2019, and too many young students came from far away place, like I don't know from where place, like really far away from Indore, and these were almost undergraduate students. These 2 students, that was a chemical biology course that I taught at that time, and they knew all about CRISPR-Cas9 in 2019, and they also knew all the backstory of CRISPR-Cas9, like which I did not know, who developed it and who got the credit and kind of stuff. Okay, but it is still a very recent thing. So and that is an outstanding tool for genome editing. Okay, so I have listed 12 things here, but that is not all. That is just few of them. Okay, which comes under gene therapy. So this is really pretty interesting stuff. So I'll go through all of these 12 of them. Okay, so this is the picture. Okay, for all those 12 things. You can see there are some spelling mistakes here, right? Anytime you see spelling mistakes, you can safely say it was made by AI, because they can make it for you, but they cannot write this correct spelling. Okay, but they look so beautiful that I've still added it here. Okay. Okay, so let's look at gene addition or gene augmentation in cancer. So suppose you have to add P53 back, you use gene addition. So restore tumor suppressor, introduce therapeutic genes like immune activating or suicide genes. You can enhance sensitivity. So a functional gene is delivered into cancer cells or surrounding tissues using viral vectors. And this new gene supplements or replaces a defective gene and adds a new therapeutic function. So P53. P10 is also a very famous tumor suppressor. So that is deleted or defective in many cancers. So you can deliver a really good P10 gene. So here the difference is we are not adding the protein. We are fixing the DNA, or we are adding the DNA. This is not enzyme replacement therapy because we're not giving the protein. We are giving the DNA. So anytime there is gene therapy, we are talking about the DNA level therapy. Okay, that is the biggest thing. Okay, so tumor suppressor P53. This is approved in China actually, not elsewhere. So they restored P53 tumor suppressor in head and neck cancer, and this is approved in China. Okay, it is still not approved in US. Suicide gene therapy is a really, really powerful method. Okay, So, one of the things which is the biggest bottleneck in cancer therapy and therapy of many other diseases is that you can give the drug, but the drug itself is very toxic to the rest of the body, right? These drugs are not fun drugs because they are supposed to kill, and something supposed to kill is bad for normal cells also. So, how can you hide the drug in such a way that it only gets activated in cancer cells? That is the trick. Okay, so what you do, you make a pro drug. So, this is a drug, but you add this pro part to that. This can go around anywhere in the body, but this is not active because it is pro. But once it gets to the tumor cells, then only this thing is removed. It gets into the tumor cell and they die. So that is suicide gene. So this is a very famous approach and pretty well established approach. So you insert genes that convert a non-toxic product into a toxic compound in cancer cells. So we don't have this gene in our body. Nobody has. No human has this thing. But what we do, if somebody has cancer, you have to deliver this DNA to that person, okay, in the tumor cells. So this DNA is for HSV-TK gene, okay, and this is a simple DNA, and all it does is that it adds a phosphate group here. So it's not a bad DNA. It is like a kinase which is adding a phosphate group. It's as simple as that. Okay, so you add this thing, and the substrate is this one here, ganciclovir. Okay, so you add this drug ganciclovir and this gene there, and this gene is expressed only in the tumor cells. So what happens is that this drug is floating around in the whole body, nothing happens, right? But in the tumor cells, you have delivered this DNA. So this DNA will make this protein and it will phosphorylate it. So once it becomes monophosphate, then other kinases in the body will make the corresponding triphosphate. This is very similar. It does not have the sugar ring, but it is very similar to nucleotide. Now, because it does not have the sugar ring, once it incorporates, the 3' hydroxyl group is missing. So the chain cannot continue, right? It is a phosphodiester linkage, 5', 3', right? 5' is there, 3' is missing. So it will get incorporated, but nothing can happen. So DNA chain will stop there and the cells will die. Are you guys following that? All of you? Because it's a 3', 5, 3 to, okay. So that stops here. So what you do is that you can give the suicide gene exactly to the tumor site, then you deliver the drug, okay? And then it will only work in the tumor thing. This is suicide gene therapy, okay? So look at this thing. You deliver the drug, the protein is made, the prodrug is only converted in the tumor cells, not in the rest of the body, and the tumor cells die. Now these drugs have a very interesting effect also. When tumor cells die, what happens is that they release this drug in the media, and this drug then goes to the actual triphosphate just gets into other cells, healthy other tumor cells, and they also die. It's like a bystander effect. Once the tumor cell slides and the drug is released, it just goes and goes to the neighboring cells, and they all die. Okay. So that was suicide gene therapy. Now let's look at immunotherapy with gene modification. So we modify the genes to get immune response. Okay, so I will tell you about 3 things here. Deliver genes encoding immune activating cytokines, cancer vaccine, and dendritic cell therapy. So if you add the genes which can make these cytokines, so once these cytokines are released, these cells come close by and they will eat up the tumor cells. So in tumor cells, you give the DNA so that they make these cytokines, and these cytokines, when they are released, this is a signal to attract the immune cells. What do macrophages do? They eat up the cancer cells. Anything comes in close contact, T cells, they will have a strong immune response, NK cells, so they get activated. So Or you can directly deliver, actually my mistake here, you don't even have to deliver the DNA for the enzymes which make it. You can actually deliver the DNA for these things directly, and they will be synthesized and released directly. So that's even simpler than that, right? You can make IL-2 in the lab. You can take the DNA, put it in E. coli, it will make it for you. But here we are putting it in we are delivering it to the tumor cells, and once it is released, these macrophages will come. Cancer vaccine therapy, you already know about it, right? You know the vaccine thing. So you take irradiated. So in this is pretty interesting. You take GM-CSF secreting. So GM-CSF, this when you take tumor cells which naturally excrete GM-CSF, or you can engineer it so that they secrete it. Now, why do you take tumor cells? Because you want to start an immune response, and then you irradiate it so that it can no longer divide, but it has all the antigens there, right? You add it there, and you inject it in a patient. So now you have an immune response, but you also have GM-CSF there. So GM-CSF is like a signal to attract all these immune cells there. So immune cells will come at the place where these tumor cells are there, and they will have a strong immune response. So DC cells uptake tumor antigens from irradiated tumor cells, and once they take it, then there is an antigen presentation. T cells will be activated, B cells will make antibodies, and there will be a strong response. Okay, even if it is not releasing GM-CSF, it's okay. Anytime you give a vaccine, immune response is going to be turned on. Okay, that is the whole thing. Dendritic cell gene therapy. So you engineer dendritic cells so that they release cytokines. Okay, cytokines, when they are released, they will attract macrophages and other immune cells. Okay, see, keep in mind what you want to do here. If you want to boost an immune response, it is very simple. You have to call the immune cells close to the tumor site. How do you call the immune cells? By releasing cytokines. Cytokines are if you release the cytokines, the immune cells will come running in that area. Okay, so if you want to boost and you have to release cytokines, how do you release cytokines? You put the DNA for the cytokines there. So cytokines will be synthesized, they will be released. When they are released, immune cells will come close by, they will eat it up, or they will kill it, right? So that's immune boosting. Or you can deliver the drug, or you can take NK cells, which are immune cells, and you also make them like that they are releasing cytokines. So they will go there, they will release cytokines, more immune cells will come. That is not even nanotechnology. Folate, you don't even have to do nanotechnology packaging or something. You can, yeah, it will directly bind to the drug. You can give it in the bloodstream, it will bind to the drug. The folate receptor at the surface of the cancer cells. Okay, so dendritic cell therapy, you take dendritic cells, you add the gene for the antigen and the cytokine. What antigen? So you know tumor cells express this protein like a spike protein. They don't, but let's say spike protein. So you take the DNA for the spike protein, you put it in NK cells. You put cytokine genes also in NK cells, right? Now these NK cells will express those spike things, and they will also express cytokines. Now they are releasing cytokines. Once they are inside, immune cells are coming. Now the spike is there, now the immune system is going crazy. So tumors, once they make the antibodies, tumor cells actually have those spikes, tumor cells will be killed. Okay, so antigen presentation, cytokine secretion, huge immune response. Okay, so that was immunotherapy with gene thing. Oncolytic virus therapy, I already told you before. I am going to tell you here also. So there are three mechanisms by which oncolytic viruses work. So oncolytic viruses are viruses which cannot divide in normal cells and which will not infect normal cells. They will only go in cancer cells first thing. They will only replicate in cancer cells. So let me repeat what viruses do. Even if one virus molecule infects a cell, it will go inside and it will replicate, right? Replicate. And it's like a bag full of viruses there, trillions of viruses. So the cells will, what will happen to the cell? It will burst open. All the viruses will be released. So the cell is lysed, right? These viruses will infect fresh cells, make a bag of cells, they will burst open, and they will just keep on amplifying till the whole thing is gone, right? So that's what oncolytic viruses do. Even if you don't modify them, all you have to do, they don't touch normal cells. They go in tumor cells, they replicate in tumor cells, and then they will lyse the whole tumor. It's all gone. So that's one way. So that is direct lysis. When you lyse it, what will happen if tumor cells lyse? All the antigens are showing up. So immune system will be activated. It has to get activated, right? Third thing is that you can, inside the virus, you can add toxic thing. So those things will further kill the tumor cells, right? So that's what is.
Even by accident will not infect any healthy cell.
So they are made it in. So this is known for quite a while. You can make replication defective viruses which will not touch normal cells. So in our lab, we work with viruses all the time. If we even touch it, it will not affect us. Okay, we will not touch it, but they cannot do that. So oncolytic virus will not touch normal cells, malignant cells, and they will lyse it up. Because they lyse it up, all these immune cells will show up, and a huge immune response will start up. Okay, and once the immune response starts, it will clean up the whole mess. Or you can, inside the oncolytic virus, you can put some very toxic thing which will be expressed, and that will further kill the tumor cells. So there are three ways oncolytic viruses work. Then you can add genes which will inhibit blood vessel formation. This is anti-angiogenesis thing. You know, anytime somebody is teaching, somebody is treating cancer, aggressive cancer, anti-angiogenesis inhibitor is always part of the therapy. Stopping the blood vessels is always part of a therapy. Okay, so what you do, you can add anti-angiogenic, inhibit blood formation, blood vessel formation by introducing genes that produce anti-angiogenic proteins. So one example is endostatin gene, which will inhibit VEGF is the ligand for angiogenic pathway. VEGF is vascular endothelial growth factor, which binds VEGF receptor, and that is where the signaling is turned on. Okay. So if you add endostatin gene, basically it inhibits angiogenesis. So if you have to add a gene, add this gene, and this will prevent blood vessel formation. Okay, then gene therapy for drug sensitization. So you want to make tumor cells more sensitive to the drug so that normal cells are spared and tumor cells die. So one of the things they do is to add cytosine deaminase genes, which converts 5-fluorocytosine to 5-fluorouracil, which is the active chemotherapy drug. So if you put this only in tumor cells, only tumor cells will make it, right? Normal cells will not make it. So this drug will float around in the bloodstream with no impact on normal cells. Only tumor cells will die. I can see you guys are very tired. This is the fourth one. But some more time to go, and then we'll be done. At least the lectures will be done. Okay, so you give it only to the tumor cells, and this 5-fluorouracil will only be formed here. Okay, so 5-fluorouracil is toxic in many different ways. So 5-fluorouracil creates oxidative stress. It inhibits DNA synthesis. It causes replication stress. You know, the replication, when the DNA is doing it, it is a, how many of you have studied DNA replication in the course? Most of you. You know how many proteins come together for DNA to open up and replication to occur. So when you add these kind of compounds which mimic the bases, but they are not the bases, there's a huge amount of replication stress. Okay, and that basically kills the cells. RNA gets, uracil is part of the RNA thing. So RNA is also affected. So all DNA fragmentation occurs. So all of these things basically kill the tumor cells. Okay, so These are different kinds of vectors which are used to deliver these DNAs, adenoviral, lentiviral. Sometimes you can take plasmid DNA, and sometimes you can package them in nanoparticles also to deliver the DNA. Yeah, go ahead. You have to speak with that thing. Who has it?
Ma'am, as you said, how is 5-fluorouracil is selective to cancerous cell?
5-fluorouracil. One way is that, thymidylate kinase, thymidylate synthase enzyme, the role of that is to add the CH3 group to make a thymine, right? So 5-fluorouracil is very similar to thymine, so it can bind thymidylate synthase enzyme and inhibit it. So that's one way. Second thing is that 5-fluorouracil can get the sugar with the phosphate can get attached to it because it's very similar to thymine, and then it is converted to di and triphosphate and then get incorporated in RNA and DNA. And if it gets incorporated in DNA and RNA, it's going to damage the DNA and RNA, right? Because it's not the natural base. So then, DNA repair enzymes may be able to fix it, may not be able to fix it. But the DNA structure is damaged. RNAs are damaged. So all of these things, then 5-fluorouracil will kink the DNA structure, will, distort the DNA structure because it's not the natural base. So anytime something else comes in, it is going to distort it. So, and when it is getting replicated, it will create replication stress. 500 to 1000 bases are added per second, so it will create that. So replication stress will turn on warning signal. So it just keeps adding up and the cells will die. Make sense? All right. Gene editing, cystic fibrosis, yes. Oh, so that is what was written here actually. So you do not give 5-fluorouracil as such, because if you give 5-fluorouracil as such, it will go to all the cells in the body, and so you are giving it as a prodrug, and like in this form, but you are delivering this enzyme specifically to tumor cells. This enzyme, if it is present in every cell will make the same thing. So you don't want to do that. You want to give the uniqueness to tumor cells. So you are adding, so remember we're talking about gene therapy now. So we are adding this gene, so we are delivering not the protein but the DNA of cytosine deaminase to tumor cells. So once that protein is made, then this product, cytosine deaminase, will be converted to the 5-fluorouracil. R is fluoro group here. Okay, and once it is there, so this is present only in cancer cells now, right? And then it will kill that. You don't want to do this as a systemic therapy. You don't want to give 5-fluorouracil. I mean, it is given as a chemotherapy, honestly, but it is very toxic. Chemotherapy relies on a very simple principle: kill the dividing cells. Cancer cells are dividing faster than normal dividing cells, so it's just but it is a pretty bad thing. But even today, chemotherapy is given to the people who have the best healthcare access in the world, because sometimes you have to give it, right? So you guys heard of Kate Middleton, right? Princess of Wales, right? She had cancer and she was given chemotherapy also. And she obviously has access to the best thing. So chemotherapy is still widely used, depending on. But if it is cured fast enough and the person is young enough, it's good. Old people, it's very hard. Older people, it is very hard. Gene editing. Okay, so if there is a defective gene like in cystic fibrosis, you can use many different ways. CRISPR-Cas9 is obviously the best these days, but TALEN and ZFN method is also extremely useful. To correct it, then put it back in there. Okay. So the person I was telling you about whose son has cystic fibrosis gene, so she was telling me that she's hoping that, by the time his son grows up, the science is, there to correct it, and it is there to correct it now. Okay. So now let's look at the case study, and this is where it gets very interesting. We all know about sickle cell anemia. So normal red blood cells look like this. Sickle cell anemia, they look like this. And there is only one mutation in the hemoglobin gene which makes it like this. So what did these red blood cells, when they are donut like this, they are very flexible. They can squeeze in and very nicely they can go. They have a half-life of 120 days. But this one single mutation makes them sickle cell-like. They die in 10 to 20 days, and then they aggregate and they block the blood vessels. So it's a very bad disease. So this can be fixed by CRISPR-Cas9 or gene editing techniques, and you can put it back. Okay. Then you can, many times P53 is not deleted, it is just mutated. So you can fix the mutation. You can fix the DNA, put the correct DNA back in the body. Okay. Same thing with BRCA1. APC is also tumor suppressor. You can do the same. You can actually knock out DNA repair genes in the tumor so that if you give radiation, they die. Right? You make them very sensitive because no DNA repair genes, chemotherapy, irradiation will completely kill them. Okay. Multi-drug resistance occurs because this ABCB1, this PGP glycoproteins pump it out. You remove the gene, now they cannot pump it out. So that will work. Okay. So CRISPR-Cas9 technology has made huge. We were making a mouse. I was collaborating with Paul Greengard, who was the Nobel laureate in 2000 or 2001. He was at Rockefeller. So we were both working on CDK5 kinase. So we were collaborating. And so he said he was making the mouse, genetically engineered mouse with CDK5 all the time. So he said he will make the mouse, and we divided the labor. So he will do these experiments, I will do this experiment. So in those days, it used to take almost 5-6 years to make a genetically engineered mouse. In our case, it went up to 10 years. And even after 10 years, the mouse wasn't ready. Okay, it was that hard. Okay, and if you make an engineered mouse, you would definitely get a Nature paper because it was such a big deal. CRISPR-Cas9, you make a mouse every 6 months or even shorter period of that. It's like a real piece of cake. It's such a huge advantage. Okay. So the kind of things you can do with CRISPR-Cas9 is just enormous. Different things you can do. You can edit any gene, you can put it, you can change it, you can. So if you want to make superhuman one day, this is the easiest way to do it like that. Okay, you can, any mutation which makes them bad, you fix it. You just completely fix it. Okay, and they become normal. Okay. Gene silences and knockdown. So how many of you have heard of RNAi? Only you. You other people, you have also used. But most of you have not heard of RNAi. So RNAi was a method which was discovered in 1990s. So what they did is that these scientists were working with plants. They were not even working with, animal stuff. So this plant was purple in color, so they put double the gene to this purple plant, thinking this will become dark purple. Instead, it became white. Okay, so when you add more gene, you would make it more darker than this became white, and that led to the discovery of RNAi. And that time they thought it was only in plants, but it happens in humans also. So basically, when you have the messenger RNA and you put a small piece of complementary messenger RNA, so that binds there and the cellular machinery kicks off and degrades the messenger RNA. So what happens? Protein is not expressed. Okay. So suppose I want to degrade a protein. So DNA makes RNA, RNA makes protein. So I degrade the RNA. So if RNA is not there, protein will never be made. That is called RNAi or RNA interference. So that became so popular that was discovered in 1990s, but that was a game changer. Okay, that time obviously CRISPR did not exist, so all of us were using RNAi to knock down genes. Okay, with CRISPR it is a piece of cake. You can knock out gene. You don't even have a trace of that DNA. It will never make it. Go ahead.
Can we engineer RNA also?
Just please, you can engineer RNA all the time. You can no, CRISPR works on DNA. Yeah, because if you do the DNA, it is a permanent thing, right? RNA will always be based on the DNA. Yeah, it has a shelf life, but RNAi is extremely, like, for last 25 years people are using RNAi so extensively. Even today it's just so easy to use. Okay, so that's what it is doing. If you want to silence a gene, you can use RNAi or you can use CRISPR. So if you use RNAi, see, knockdown and knockout. Knockdown means you're reducing the level of it. Knockout means complete removal. So cancer cells often rely on overexpression of oncogenes, angiogenic signals. So if you put the RNA, corresponding RNA for these things, they will be degraded. The cancer will disappear 100%. I mean, tremendously, if you are doing RNAi against the main oncogenic driver. So if you put the RNAi against MYC, complete reversal of cancer. So it makes gene silencing, right? So it inhibits tumor growth, it enhances sensitivity to therapies. Okay, so these are some of the things. Gene silencing targets, BCL2, KRAS, oh my God, so important. VEGF, this is angiogenesis one. If you make it disappear, make EGFR, PDL1, they are not even expressed. So the point is you are attacking at the RNA level, right? But now you do it with the CRISPR, you attack at the DNA level, and that is permanent. Okay, so this is current clinical trial and successes. This is about the T. So you can make PD1 knockout. Knockout means you have used CRISPR in this one. See, CRISPR Cas9 here. You can do many different things. All right. Now, what are the challenges in cancer gene editing? Off-target effects. You want to cut only at one place in the whole genome, but if the sequence is a little bit similar, it can cut at the wrong place too. So you have to be very smart about it. Okay, tumor heterogeneity, it's not only one kind of thing. A tumor has many different kind of things going on. So if you target one gene, you may not be able to reduce the tumor completely because there are other factors also going on in there. Okay. It is hard to target deep or solid tumors directly, especially if they are deep inside the body. Skin cancer is easier to treat because it is outside. Surgery is possible, therapy is possible. Something which is deep inside is harder, especially the tumor is very deep. And obviously the ethics and regulatory things always kick in. Okay. Mechanisms of gene silencing RNAi. Before RNAi was discovered, people were using antisense technology, oligonucleotides. Do you guys know about antisense thing? Complementary sequences to do that. Yeah, there was a big company there. This company was close to San Diego in a place called Carlsbad, which is really beautiful in California. And it was a very famous company. The company's name was ISIS. And when the other ISIS came into existence, they had to change the name of the company because it was like nobody would want to even hear the name ISIS there. So they were the world leaders in antisense oligonucleotides. Okay, microRNAs or mimics or inhibitor CRISPR. Without going into details, these are the ways you can knock down the gene. CRISPR will knock out the gene. Okay, so siRNA, 3' are small interfering RNAs. shRNA are the same thing, but instead of giving RNA every single time to the cell, you clone the DNA in a vector, in a plasmid, and you give the plasmid to the cell. So this will make the RNA all the time to complement with the messenger RNA to degrade it. So once you do it, you don't have to worry about it anytime. It will always keep the expression down. Okay, but if you use siRNA, you have to keep adding it every few days. Okay, because RNA will degrade, then you add it again, then you add it again, then you add it again. Here it will constant supply. Okay, antisense are chemically modified DNA or RNA sequences that bind complementary messenger mRNA. Now nobody uses ASO because we have so many better techniques. Okay, CRISPR is there. MicroRNAs are also small pieces of RNA which will bind to the sequence, and when they bind to the sequence, they can degrade it, or they can bind to the promoter region and inhibit transcription, or they can bind to some part of the RNA and they can inhibit translation, or they can activate translation. So they have a variety of functions. Okay. So what are the advantages and limitations of gene editing? You can do highly specific targeting, but delivery challenges are there. Reversible in most cases, off-target effects are possible. You can target undruggable. If you're targeting DNA, there is nothing undruggable about DNA. DNA is just a sequence. You can definitely target it. So these kind of things are often used in combination with other therapies. Okay, I can see you guys are extremely tired. Maybe 4 lectures is not a great idea. Think about the Christmas thing once again. Okay, this is just a beautiful picture. It's not telling you much. Let's go to CAR T therapy. We can also stop here and but the dinner, oh, it is already 1. Anyway, why don't we stop here? We can pick this thing up after lunch, because if you're too tired to understand it, there's no point in my finishing it just because we have to finish it. CAR T is way too interesting to just, so let's have a,
do after lunch.
we can do after
Another 15-20 minutes, this lecture will be.
maybe 10 minutes. Yeah, 10, at the most 15 minutes. So let's stop here anyway. And
Do after lunch, it will be good. Okay.
because after lunch it's just tutorial, right? And that is a relaxing time, so you guys can ask questions. Antigen presenting cells, they express PD-L1, which is L stands for ligand, and T cells, they express PD-1. So if PD-L1 locks with PD-1, T cells become quiescent. So this is a natural mechanism to inhibit autoimmunity. So T cells, when they're hyperactive, they will start destroying everything, and in that hyperactive state, while they are cleaning up all the foreign mess, they can also damage our body. So that is why this is why nature has designed the PD-L1 on APC cells and some other cells. They come and they lock with T cells, and T cells become quiescent. So what tumor cells do, they also express PD-L1 and they lock with T cells, and T cells become quiescent, right? So if you break this interaction, so how do you break this interaction? You make a PD-L1 antibody which has even higher affinity. So now tumor cells have PD-1 and T cells have tumor cells have PD-L1 because they are locking it with this one. So T cells have PD-1, and if you make PD-1 antibody, that will be locked, so tumor cells are going to be there. Or you can make PD-L1 antibody, so you can lock the PD-L1 on tumor side so that they cannot form that bond with the T cells. Is it making sense? Right? So You can even remove PD-1 completely from tumor cells, right? PD-1 from T cells. So if you remove T cells, they don't have PD-1. Tumor cells can express PD-L1, but there is nothing to bind there. So you are making T cells which cannot be switched off, right? Because there is no PD-1 there. Not making sense? No, I will show you the picture because this is something you have to show it via picture. This is too much information. So T cells have PD-1, okay? T cells have PD-1. Tumor cells are not supposed to have the ligand for PD-1, which is PD-L1, but they do express it. So this PD-L1 locks with PD-1, and as soon as it locks, these cells become quiescent, okay? So what if you remove PD-1 from T cells? Okay, now T cells are going to be active all the time. So PD-L1 has nothing to bind. So they will remain active and they will kill cancer cell. Is it making sense? So that's what it is. So that is what was said there, that you can engineer T cells to have no PD-1. And if they have no PD-1, there is no off switch there. You keep them on all the time. So they will kill the tumor cells. Now let's go to CAR T therapy. So what you do, you take out the T cells, which can be from a healthy donor, allogenic, or you can take it out from the patient itself, and then you grow it in the lab, and then you add the DNA through a virus into these T cells so that they express these receptors. These receptors are these are the natural receptors. When you put the virus in there, depending on the DNA, now they will make these receptors. These are the chimeric antigen receptor, these orange ones, okay? So what are these receptors binding? They are against the cancer cells. So when cancer cells come, they bind, and once they bind, they basically kill the cancer cells. They also release cytokines. There are many different kinds of CAR T receptors, okay? So cancer cells eventually dies. That's CAR T receptor, okay? Here is the thing. Suppose a patient has cancer and you take out T cells from them. The patient has probably undergone chemotherapy or radiation therapy. So the patient is not healthy at that stage, and you're taking out T cells from the body, which is probably the only way to do it, but it is even more taxing. Then you engineer all these things, which may take weeks to months. The patient may not have that long to wait. So in ideal situation, you want CAR T cells ready so that you can directly inject it in the patients. So what they do, they take it out from healthy donors, okay? So autologous means that you are taking it from the patient and putting it back in the patient. So there is no immune rejection here. But allogenic means you are taking it from healthy donors, and there is going to be immune rejection, right? Especially if you give to many people, high percentage of people are going to reject it. So the good news is that by this time we already know what are the features in these receptors, like what are the warning signs for the body to recognize it as self versus foreign. So what we do, we know the body is going to look for these 5 receptors as self versus foreign. So we remove those 5 receptors, okay? If we remove it, immune system cannot recognize whether it is self or foreign. Make sense? So this is what is shown here. You don't have to remember anything, but see. So there are 2 things which can happen. The donor T cells attack host tissues because donor T cells recognize host as foreign. So they are attacking. That is called graft versus host disease. Forget about host attacking T cells. The foreign T cells are attacking the host. So we know what leads to that. So T cell attack via T cell receptor, TCR. Remove TCR, T cells cannot attack the host cells, right? So we can fix that problem. But then host cells also will attack the T cells as foreign. So we have to remove all the things which will allow the host cells to recognize T cells as foreign. So in here, this B, C, D, E, E. So in this one, we have done TCR knockdown, T cell receptor knockout. So when we do that, this cannot happen. So T cells cannot attack the host cells. So we have taken care of one problem. Now we also want to make sure the body does not attack the T cells, otherwise they will be gone. So there is so many things we have to do. We have to knock out CD52, we have to knock out CD7, we have to change HLA A and B, then we have to do a lot of things. We have to knock out HLA2. These are different kinds of modifications we have to make before we add the T cells, and then the host body cannot recognize that this is foreign. All the things by which they recognize have been changed or removed completely. So human body cannot recognize this as foreign either, right? So now the CAR T cells are ready in the pharmacy, right? The moment you need, you can add it. Patient is not going to reject it. They are not going to attack the patient, and they're ready to go. So the doctor writes it, you immediately get it. Okay? So that is prevent rejection in allogenic off-the-shelf CAR T cells. So you engineer CAR T. So they are showing all the receptors, chimeric antigen receptor, but they also have all these other features there. This has already been done. Okay, we already know exactly how to do it. So let me ask you, what are these CARs? What are these CARs against? What is the function of CAR, chimeric antigen receptor? Tumor cells, very good. So even if you give in the bloodstream, it is going to only go to the tumor site and get locked there and kill it. Okay. So that was CAR T cell therapy in very simple words. Then gene blocking therapy is very simple. So this is a gene which is, overexpressed. You add a blocking gene, it inhibits the expression of this thing, cell works normally. You take a cancer cell, you make it normal. Okay, you don't even have to kill it. Then let's look at ex vivo versus in vivo. Do you know what is ex vivo versus in vivo gene therapy? Can anyone explain to me? Yes. You need that. Anshul, right? Anshul? Rohit. I should not even try to say the names because I'm going to use all the wrong names on record.
Like ex vivo gene therapy suggests we are taking out the cell from the body and we are correcting it,
And then we are
and then
adding
we are
it.
adding it back again.
Exactly.
And in vivo means it's on the inside the
Body,
host.
it is being corrected. So there are two ways to correct it. That's exactly what it is. Okay. So in ex vivo, you take out the cells from the body, you modify it, you put it back in. For in vivo, you do the gene therapy directly in the human body and it is corrected there. So ex vivo, you collect it, you change it, and then you turn it back there and you constitute it. Okay. And in vivo, you directly give the local injection to the site and then it corrects itself inside the body. Okay. The last thing is epigenetic gene therapy. Okay. Why epigenetic gene therapy? Because epigenetics is the one which is controlling gene expression. So you can actually do epigenetic gene therapy. So for example, this TET1 is a demethylase. Okay. So this is switched off. You can give the DNA to this DNA. The gene is turned on. Okay, DNMTA3A. It is turned off. You can give the. You can. This is hyperactive, and it is doing the tumor suppressor methylation. So you can turn it off by knocking it out, basically through Cas9. The gene is turned off. Similarly, you can do. For P300, you can add histone acetylation so that it opens up and it expresses P300 protein. For KRAB, this is an oncogene, so you add repressive histone markers. What are repressive histone marks? So that which will switch off gene expression. Which one? Methylation. Very good. Methylation of histones. So this is highly precise and modifies gene expression without cutting the DNA. Okay. So I'm sorry, here when you do it, here you add repressive histone marks, you do not, for this you do target methylation, you don't knock out, because I'm talking about epigenetic markers here, okay? So this you already know, right, epigenetics. So, and so one thing is that if you have to use it through small molecule, you use the inhibitor. If you use epigenetic way, you can do the gene expression by changing the epigenetics there. Okay, and that's it. We finished it in 13 minutes. I was saying 10 to 15 minutes is done. Now we officially start the tutorial session. So, so how do we start? So I should ask questions or you're going to ask questions? Let's start with you asking question. Okay, so you have the mic. Yeah, go ahead.
Like you have said that like TET1 knockout or DNMT3A knockout. Actually, like if we do the knockout, it is totally irreversible. And we
Yes.
know like DNMT3A or 1011 translocase 1, that
Yeah.
particular enzymes have a very over, like we can say like it has many different roles it plays. If we like totally knocked it out, then like
That is a very good point. So tell me, how will you switch it off without knocking it out?
like ma'am, it should be like in my perception it should be like reversible, not totally knocked out.
Yeah, so how would you make it? I agree with you 100%. How would you do it?
Knockdown can be possible, or small molecule inhibitors can be possible.
But if you are dealing with gene therapy, right? This is under gene therapy. How would you do that?
Yeah, like ma'am, RNA no.
Think about it. See, before I answer your question, let me say something. So this is always the case that people find some target like DNMT3A, right? Or calpain, that is a protease. So the whole world thinks, oh, we found the main target, let's knock it out, right? Or knock it down. And then what happens, they realize, oh, this has many good functions, and the whole body falls apart. So you cannot knock it out or knock it down, right? So you are absolutely right, because it has a lot of good functions too. So what do you do then? You can obviously use small molecule inhibitor. What else can you do? So in cell lines, it is easy to do reversible inhibition using small molecules. So you add it and it will get, so shRNA, siRNA, right? It is inducible also, that whenever you add doxycycline, it will be knocked down. When you remove doxycycline, it will come back. So you can do reversible. I don't think people will do it in humans that way. Okay, so unless it is safe to knock it out, you would not knock it out, you would use the inhibitor. But you can also think about epigenetically regulating the expression of TET protein, right? So TET is epigenetically regulating other things, but you can also epigenetically regulate TET itself also, right? So you can go further upstream. But this is a very good point. You just don't want to knock out just because it is doing one bad thing. You have to weigh the pros and cons of everything. And sometimes it is good to be reversible in that respect. So, yeah. Go ahead.
Ma'am, my doubt was we talked about cancer vaccines, and in a normal vaccine, the procedure is that you attenuate the causative organism to the point that it is no more infective, but it still has the characteristic protein expression that we need for the immune response. But in case of if we are trying to do it for cancer, wouldn't it require a higher degree of attenuation because cancer cells or tumor cells have many such things that could induce cancer as
Oh,
well?
100%. Huge amount of this thing. You have to really kill them so badly that there is no way even one single cancer cell is alive there, because otherwise we are introducing cancer there. So they have to be like really dead, dead, dead. And I would not be surprised if they mechanically lyse it up without destroying the proteins. So yeah, you have to do that. You don't want to introduce cancer there.
Another doubt that I had was that we talked about oncolytic viruses. So you had told us that the viral DNA is edited in a manner that it does not, the infective parts of the DNA are removed and only the part that we need to introduce into the cell is kept. So how does our immune system respond to such a viral invasion? Does it have a like triggered response, or does it not treat it as such?
So it has to be modified in such a way. So what you do is that you give it in very small amount, okay? And it is engineered. So you can even make virus coated in some nanoparticles, and nanoparticles are coated with, let's say, folate. So cancer cells express folate receptors, right? So nanoparticle is hiding the virus, or you can even make virus which are expressing something which is recognized by the cancer cells, and you don't give too much virus. So basically the virus will go inside the cancer cells, bind there, and it will infect it. Now I don't know what, so this I know very well. You know, virus have viral proteins and coating proteins and all of these things. So these things are known for decades and decades now, right? So it was discovered in 1980s. So we know exactly what to mutate, what to remove, so that it does not touch normal cells. Now imagine that one virus particle going inside tumor cell, but they are replication. They can replicate in tumor cells. So they are replicating, and the way they replicate is that they will form trillions of viruses within a cell, and the cell cannot, whole cell is completely dead by that time. So it will lyse up and just burst open, right? So then these trillions of viruses will come out, but they are next to the tumor, they are within the tumor, and they are infecting more tumor cells and more tumor cells, and in no time the whole tumor will be eradicated, right, in an ideal situation. So those viruses are meant to replicate only in the tumor cells. So even if you don't add any toxin to the virus, just by virtue of replicating, it is lysing the tumor cells. But then because it is lysing the tumor cells, all the tumor antigens are exposed now. So immune system will kick in. It is like a really hot thing for immune system. So immune system will start attacking. And the third thing is that you can always add further toxin to the virus, which is further released there. So there are many ways to do it. Yes. Go ahead, go ahead. You guys are the first time attendees here, right?
Yes.
Yeah.
Ma'am, how can we integrate any gene of interest into only cancer cell in vivo? That means how can we target only cancer cell in vivo?
Oh, that
If
is
it is based on their microenvironment or something.
no. So that is actually super easy to do. What happens is that cancer cells have their own special things expressing at the cell surface, right? So folate is one of them. They express folate receptors, and the reason they express folate receptors, have you guys heard of tetrahydrofolate? You have heard, right? And why is tetrahydrofolate is so important? Because you remember it carries the methyl group, the methylene group, 5-10 methylene THFs, 5 methyl THF, 10 methyl THF. So it is a one carbon donor, you know that, right? So this one carbon donor is very useful for the synthesis of thymine, okay? And how will you describe cancer? In the most simplest word, uncontrolled cell proliferation. That's the first thing. Before even we say metastasis, we say uncontrolled cell proliferation. So if something is proliferating, DNA has to get replicated all the time. And if DNA is replicated, it needs a constant supply of nucleotides. So nucleotides are shared between DNA and RNA, right? They both use. But thymine is unique to DNA, right? So basically, when DNA is replicating, in addition to GTP, ATP, CTP, it also needs TTP, right? So it needs a constant supply of thymine. For constant supply of thymine, it needs tetrahydrofolate, which can deliver the methyl group. For tetrahydrofolate, it needs folate to start with. So cancer cells develop these folate receptors so that they can intake folate there. So we scientists have made use of this property of cancer cells. So folate receptor is just a receptor, right? But folate itself is a small molecule, very easy to modify. So what we do, Professor Venkatesh has worked on this thing during his postdoc. So folate, this is a molecule folate, you attach a linker, and then with a linker you can add anything of your choice there. So suppose you add a fluorescent FITC or rhodamine or anything there. So then it will come and bind preferably to cancer cells because they overexpress, right? And cancer cells will light up. So this has been approved in Europe already, that you can use folate coupled to fluorescent molecule, inject it in patients, and the patient's tumors will light up, and the surgeons use it while doing surgery. So it is extremely precise, correct? Now instead of adding a fluorescent molecule, you can attach a therapeutic drug. So it is walking around everywhere, but it is going to get concentrated on the tumor, and the therapeutic will be delivered to the tumor cell. So I just gave you an example of folate receptor. There are many, many different things which is expressed there. Now, let me tell you something else. Have you guys heard of RNA aptamer or DNA aptamer? Have you heard of it? No. So aptamers are basically what they are, secondary tertiary structures of DNA and RNA. So this is not double-stranded DNA. It is just a piece of DNA, and you do what is it called, Cell-X. Have you heard of Cell-X? No, that's okay. It doesn't matter. You make trillions of DNA molecules with all possible combinations, right? With error-prone PCR, or you can do chemical synthesis. And then you take your target of interest and you do binding assay. Without going into details, you can find the DNA or RNA which binds specifically to some target. So if you look at the DNA, it is just a short piece of DNA with the certain tertiary structure. And because of the certain tertiary structure, it is binding this very tightly. So those are called aptamers. So you can even take a DNA aptamer once it is recognized. You synthesize it in a chemical synthesizer, or you do it yourself. It's not a big deal. You synthesize it, you attach your thing. Every single time when you have that sequence, it will fold in the same way. You know that, right? It's like the protein. If it has the same sequence, you can make it in the universe anywhere I cannot say anywhere in the universe. I don't know what happens outside of Earth. But on Earth, anywhere you make it, it will fold in the same way. Same thing for DNA aptamer. So once you know the sequence, you synthesize it, you attach it to anything you want, and it will bind to the cancer cells. So basically, you can even take cancer cells and use it for screening to make aptamers, even if you don't know the receptor or anything. So what you do, you take normal cells, you take cancer cells, and you can see which DNA binds here but doesn't bind here. So you can select it. Once you have that tool, you can attach anything you want, fluorescent molecule, drug, radioactivity, toxin, whatever you want. It will go to the tumor cells. Then you can also do this thing that you can take nanoparticles, right? You can make a nanoparticle. Think of nanoparticle like a box. You can put anything you want inside the nanoparticle. Outside, you put those aptamers. It will be delivered to the tumor. So let me tell you one more thing. So you guys are very worried about the tumor microenvironment, and you should be worried about the tumor microenvironment. But there are some tumors where tumor is more accessible than other tumors. Like pancreatic tumors are not accessible, but other tumors are accessible despite the microenvironment. If the microenvironment is very acidic, you might want to consider really using nanoparticles or something. But anything cancer does, we make use of it. Uh, yeah, I think it is in one of your lecture in this one also. I teach so much that I'm confused where I've included that thing. So see, you guys can really enjoy this thing. So microenvironment is acidic because it releases acid. Why it releases acid? Because the immune cells are ineffective there. But now we know you guys, like cancer cells are secreting acid. So now we make a linker which is pH sensitive. So it is it will not fall apart anywhere in the body except in the tumor microenvironment. When it falls apart, stuff gets inside the tumor. So when to dal my path. So whatever they do, we find the answer to that. We make use of their own thing and attack that way. Answers your question? Yeah. All right, guys. All I can see is that after lunch, at least everyone is awake. We needed that break, right? Go ahead.
So, ma'am, is oncolytic virus therapy only one-time therapy because our immune system will identify the virus and next time it will act as a vaccine kind of way, and our immune system will identify the virus for the next time, and it might get killed earlier
Yeah,
before reaching the tumor.
that is a good question. I would think that it should be a one-time therapy, but the problem is that the cancer cells keep mutating, keep mutating, keep mutating. So even if oncolytic virus attacks, there is a chance that some cells survive and then they will mutate it, and they will. This is a very well-known fact. If you make anything against a known antigen, they will hide that antigen. So they will not express that antigen, and the immune system will be fooled. So, even for COVID, right? The virus is mutating. That's why we keep getting vaccines. I also got a alert in my phone. Come for the vaccine thing because COVID cases are at rise again, and virus is mutating. So whatever vaccine we have already taken, we have immunity. If COVID comes in that form, we don't have to do anything because our body will fight it off. All the B cells are there. But if COVID changes the whole spike protein, and if our body has never encountered it, it's again a new story, right? So viruses mutate very fast, you know that, right? So do cancer cells. So whatever is the recognition element which got them attacked, they will make it disappear. So it is just it is a constant fight with this thing. Having said that, many cancers are eradicated. I know of a person very close to me in my family. So she got extremely severe cancer and it is completely eradicated.
Virus which we are using, so if we are going to do the oncolytic virus therapy second time, we will need to change our virus too, na? Because our virus will be recognized by the immune system, so before reaching the tumor our virus will get killed by the immune system because it's a foreign particle.
No, so what you do is this. You first of all, you don't give a very high dose of the virus, and you can make the virus pretty anti-immunogenic. You can hide the virus, you can like wrap it up in a nanoparticle or something. So virus itself is not triggering the immune system. Okay, it is that when virus gets inside the cells and start replicating, that's when the whole cells fall apart. So virus you can make non-immunogenic. See, you know, You guys know that antibodies are raised in rabbits, polyclonal. You all know that, right? So long time ago, when I was a postdoc, we wanted to make an antibody towards a target I was working on, right? So in those days, antibodies were not that easily available like they are here. So I wanted to make it. So I was a chemist, so I made the whole peptide, synthesized the peptide myself. We didn't have a synthesizer. So I don't know how long it was, 10 mer, 20 mer synthesized. And that was against my protein, right? So I made it. But if I inject, I had to send it to some company for injection. But if I send the peptide and they inject it, it will not trigger immune response. So I had to couple it to KLH and do something so that it actually triggers immune response. So you can make the virus so that it is non-immunogenic, like in some way. I don't know which way they do it. So that itself does not do the immune response. So keep in mind, when you give the oncolytic virus the very first time, immune cells are only coming after the tumor cells are lysed, and immune cells are coming against the tumor antigens, not the virus. Make sense? And if virus should trigger immune response, because COVID virus triggers an immune response, right? So the chances are that they change it in such a way that it doesn't trigger immune response, or they package it in something.
I have one more doubt. How does ubiquinone like how does ubiquitin ligase identify the protein of interest?
So what happens is this. So I will tell you about the ubiquitin system, not tomorrow, but on Monday, because tomorrow we don't have any class. So there are three enzymes, E1, E2, and E3 enzyme. Okay. So E1, first the substrate will bind E1. E1 will come, then E2 will come, then E3 will. E3 is the biggest one. Okay. So E3 is the biggest one. So on one side it will recognize the substrate, and E1, E2 are all there. So then it will. So it is when the whole complex is formed, it is the E3 which recognizes the substrate. So you have a lot more E3 than E2 and E1. So E3 is like a big adapter protein which is bound to E2 and E1 and also the substrate. And it is the E3 which is recognizing the substrate. It will not make sense till I show you, because it's the whole ubiquitin machinery. So I have to show you the whole thing before you understand what I'm saying. But the bottom line is that when you make PROTAC, you have two handles. One part recognizes the substrate, one part brings in that machinery. And once it is in close proximity, ubiquitin tag is added to the protein of interest and it gets degraded. It is very easy to simplify to understand once I have all the images there. Because many times only hand waving doesn't help, you know. So you have to see the actual picture. But thank you for asking me, because I will now make sure that I have, I don't have those, I have a lot of figures, but I will go even more basic to explain you simple ubiquitination mechanism independent of PROTACs first. And I have it everything at home, but I obviously have not brought it here, but I can pull it out of the web and show you guys everything. I am supposed to ask you some questions too. Yes, go ahead while I'm thinking.
Ma'am, if a person is reacting to a drug, harshly reacting to the drug while others are taking it easily, how do we identify, is it because of genetics or epigenetics?
If it is due to epigenetics also, it is affecting the expression level of proteins, right? Actually, you have asked a very good question. I will open the floor for everyone to answer this question. Okay, so you pose the question on my behalf. This is a really excellent question. Can you repeat it? And let's see what you guys come up with.
So, if a person is reacting to a drug harshly while others are taking it easily, how do we identify if it is genetic or epigenetic?
That is very, very, very good question. I mean, that is just really fabulous question. Think about it and tell me. Yes. Rohit. Okay. If I remember tomorrow, then I will pat myself.
Like ma'am, for genetic cases, we will first like target the genetic. We will do PCR for particular receptor if it is expressed for the drug. So
So what kind of PCR will you do if you have to see whether it is overexpressed?
like normal PCR, real time PCR.
Real time.
Yeah.
Very good. QRT PCR.
Yeah.
Very good. Yes.
Real time PCR. If it is like normal, in case like genetic, after doing real time PCR, like if it is normal, then we will go for like epigenetics. So we will do attack sequencing, or we
Chip
can
seq
chip
sequencing.
sequencing, attack sequencing to
But how will you? So here is the thing. How will you know there are 30,000 genes? Where will you attack? Like where will you focus?
yeah,
How will you?
like promoter region of the particular gene, which is
particular gene you will go
a
after?
particular receptor for that, like it is responsible for the drug, like
No, so see, the question is you are Venkatesh, right? So the Venkatesh's question is that if a person is reacting harshly to a drug, so keep in mind he's saying harshly to a drug. Okay, so that means we have already decided the drug. And if we have already decided the drug, we already know the receptor, right? But he's reacting harshly to the drug. So do you think it is because of the receptor? All of you, it's open to all of you. This is actually such an excellent question because it will cover everything that we discussed today, every single thing that we discussed today, right? So let's go back to HER2 because every time we go back to HER2, right? So we are doing HER2 here, okay? So we know this patient expresses HER2 receptor and we are using Herceptin or we are using Lapatinib. There are many HER2 receptor things, right? So we know the receptor, okay? We know the target. But if it is, what are the possible reason for the patient to have an adverse reaction to the drug that we are administering? What could be the possible things? Let's make a list of those and then we attack that thing. Can you guys tell me? So do you think, is it because HER2 is overexpressed or HER2 is not expressed? Even before you do qPCR, what is your hypothesis? So you tell me, what is your hypothesis? Do you think the patient is having nausea and all of these things because of HER2 receptor? So here is the thing, if all the patients across the board are having bad this thing, you can say the drug is toxic, right? But someone is having toxicity, others are not, right? That's what you're saying. So what would you think? What is going on? Shivani, you want to try? Hyperimmune response, why? Because others are not having hyperimmune response. I'm going to be the devil's advocate here, so don't take it
can be because of
personally.
metabolism as well.
It could be due to metabolism. So we have to get out of the targeted therapy right now and we have to go to the metabolism. So now you have guessed it is due to metabolism. What would you do? You were going to say something, right? Please, 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 you have to use it. It has to be recorded.
It could be due to the drug uptake as well if it is not being uptaken properly, if it is too slow and the amount is being accumulated too much and there is a toxicity due to that. That could be also the case.
That is also the case. So it could be drug uptake issue, it could be drug metabolism issue, it could be anything due to all the PGX we said. So now you have narrowed down it is due to PGX. What would you do? What will you guys do?
Like as we do that study, which enzymes are like not playing their role, like analysis in pharmacogenomics, what we learn.
Yes, so there is already a list of like 20, 30
that
genes. We will check those
you
genes.
can check transporters and the metabolizing enzymes as well, transporters and all that is responsible for pharmacodynamics and kinetics.
So we will do QRT PCR and we'll look at the levels of those things. And what if all the levels are equal, then what will you do? So between normal and this patient, they are equal, then what will you do next? Tell me. You have to use the mic.
So, if normal and the other guys PCR result are same, then we can conclude it is epigenetic.
No. Because epigenetics is expression of gene, and if it is equal, then it is definitely not epigenetics. You will rule that out, right? Because epigenetics is gene expression. Correct? So you have ruled out epigenetics here. But then what next? Huh? So, I want you to think before I say anything. So DNA makes RNA, RNA makes protein. So you did QRT-PCR and all the genes are expressed at the same level, right? So, and epigenetics is controlling gene expression. It seems they are the same. Hey, don't hesitate to say anything because I may be missing it. If something is, just say it. Do you think epigenetic could be playing a role? Because I'm also thinking as you pose the question, right? Don't be afraid. We are just throwing ideas here.
I'm not sure about it, but ma'am, when we do RT-PCR, our final result is sequence. If I'm going in right way, the DNA sequence, I guess.
Very good.
So
I was hoping somebody says that. So if QRT-PCR results are the same, then you also have to do DNA sequencing. What if RNA levels are the same, but the proteins are mutated? And if the proteins are mutated, they're going to work differently. So you will sequence the DNA, right? You absolutely need to sequence the DNA. So suppose the sequences are wrong, then you have answered your question. It is at the genetic level, not at the epigenetic level. Now let's go further than that. What if your DNA sequence is also identical? What will you do then? You have asked such an excellent question. I don't have to plan anything because the whole thing is covered in this one question. Tell me. So DNA sequence is identical, correct? What is it? DNA sequence is identical. Epigenetics is not very important role, or at least because expression level is the same. So what else is going on? At the protein level. So what would you do? Very good. So what would you do at the protein level?
We can check with the immunoblot techniques.
Exactly. You will check it because it is only 20-30 proteins. You definitely can do with immunoblotting, and it is entirely possible that the RNAs are equal, proteins are not equal. Definitely possible. Why? Because protein degradation rate may be different, right? Then protein modifications could be different also, right? So then you will go to the check at the protein level, and the chances are that you will find the protein levels are not equal. Okay, now let's assume that the protein levels are also equal. Now what will you do? So obviously there is a scenario that we have not yet discovered that gene which gene is playing a role, right? Because we are focused on these 20-30 genes thinking they will answer all the questions. So that is always a possibility. But before you throw out these 20-30 genes out of the picture, right? What is the one other thing you can do which will conclusively tell that if these genes are involved or not involved? In that case, you will make the protein, isolate the protein from these cells, not make it, and look at their activities in vitro, because their activities may be different. So you know what? You may argue, well, there is no, if there is a mutation, their activity are going to be different, right? But your DNA, so if you see mutation, then obviously you will go and check the activities, right? Because with the mutation, the activities are going to be altered, correct? But in case the mutation has not shown you, I mean, the DNA sequencing has shown no mutation, but the activities are different. How is that possible? So that would be, in that case, that something else in the cell is impacting this protein. And there is another player involved which is controlling the activity of this protein. Maybe it is binding, maybe it is attaching to it, or maybe something, or maybe it has changed its localization or something, and that way it is altered. So to sum it up, you will look at the RNA, you will look at the DNA sequence, you will look at the protein levels. After all of this, you are going to check the activity of each of these enzymes. Because if you remember, activities were different in each case. Usually it is, so in the case that I showed you, they were mutated at the DNA level. So QRT-PCR would not have told us that much, but having said that, the levels were also different. So QRT-PCR would have shown at the RNA level, but not at the protein level. So you have to look at QRT-PCR, you have to look at the protein level, you have to measure the activity. And if all of these things show nothing, then there is something else involved there. Okay. Now, finally, I come back to the target. Okay. So let's say you find nothing going wrong. Okay. And the patient has a lot of toxicity. So what else could be wrong?
It can be liver function.
It could be liver function, but now I am actually going back to where you started, the target. So it is possible, well, I am assuming that the person has already sequenced the target and has ensured that the target itself is not mutated, but there is a possibility that this patient who is responding badly, the target has been mutated and it is no longer binding the drug. So as it is getting exposed, so now I'm getting back to the target, and because it is not binding there, it is not, other than the metabolism, it is like statin, it is not being used. And so I don't know, the target itself could contribute in some way, because it is not like other people, it is getting, they are getting better. This person is not getting better because drug is not engaging with the target. So that could be the toxicity issue, because others are going in the right directions and he is deteriorating, or he or she is deteriorating. And having said that, most of the small molecular inhibitors, including Gleevec, they have severe side effects, independent of metabolism and all these things, because they hit many other targets. So these are pretty toxic drugs, right? We are dealing with a toxic disease, so the drugs are toxic too. So excellent question. We covered a lot of topics. So if you are an oncologist and if you have to really prescribe a drug, so first thing is to really find that what kind of cancer it is, right? So somebody comes with liver cancer, right? So you have to figure out why this cancer occurred. Is it a viral infection, right? Sometimes it is at such an advanced stage you don't have time to do all these things, but you have to find, in case of liver cancer, if specific types are known which express receptors, you have to test quickly for all of these things to ensure that, right? And then once you know what is the best therapy that you can give, then you go for the targeted therapy as the first choice. If that is not a choice, then you go for immunotherapy and chemotherapy. If surgery is a choice, you go for surgery, if it is a choice. In US, in few places they do something called histocrispy or something like that. I've heard it recently. So if somebody has lung metastasis, they can manually go and clean up that thing, but it is very complicated process. So they do it under certain circumstances, like when the patient is recovering, the patient is responding to chemotherapy because they are afraid that they will do such an invasive process and the cancer will spread anyway. So when cancer comes under control, they think they can do it, but it is still pretty, yeah. So there are ways, but the bottom line is that if it is not good today, it will get better tomorrow. In the last 10 years, we have made miraculous progress. Like I was telling you about this faculty member who had cancer, right? 2-3 years ago, and he had to sign so many paperwork for 3 weeks before he was given immunotherapy, and it was too late by that time. So, and now it is given worldwide. So it is very rapidly increasing. You saw how, and immunotherapy is biologics, right? It's PD-1 and VEGF inhibitors antibodies. So these are antibodies. And all major cities have these facilities here in India. I don't know about rural places. I have no idea, but I know major cities have. One last question before we can go for tea. Do you guys want to continue after tea? We should continue. We should continue. Any other question, anyone? Yes, yes, go ahead. Uh,
Actually, I have a confusion. Like I get confused when these things like you said immunoblot, then RT-qPCR. So we didn't explicitly study these things. So I get confused. Like what is the mechanism? Can you briefly tell me what it exactly gives you like results? That day also you mentioned that RNA chip and
yeah, absolutely, absolutely. So let me ask you something. Do you know about, suppose you have to, why do you even look at the RNA levels? Why can't you look at the DNA itself? Can anyone tell me this thing? So when you're comparing two parts like normal cells and cancer cells, why do you look at RNA? Why don't you look at DNA of normal? Why don't you look at the levels of DNA? Huh? I am asking you such a stupid question. You are answering it very, in a very reasonable manner. You are thinking my question is genuine. It is not a genuine question. It is actually a pretty stupid question, and I want you to answer it in that way. So don't explain to me. Don't think I'm telling you the right thing. So, because I'm asking you really weird question, the weirdest question I've ever asked. Hey, anyone tell me, why don't you measure the DNA levels instead of RNA levels? Why do you have to go to RNA levels? But DNA is the father of RNA, so why don't you look at the DNA levels? Yeah, so why can't you check the expression level of DNA? That's the thing. DNA may express, may not express, but even better answer is what? DNA levels will never change. DNA is DNA. It is just that one copy there, haploid or diploid, right? So there is no DNA level, right? Okay, and second, this is first thing, there is no DNA level. DNA is always exactly the same in every cell of our body, first thing. Second thing, as you said, 5% of the DNA will make messenger RNA. So why would you ever look at DNA? It makes zero sense to look at DNA, correct? Yeah, see, so I have to trick you. You have to answer me with the same thing. Okay, you cannot test. So, okay, sometimes you have to throw this thing. RNA, okay, so we cannot check DNA. We have to check RNA. So why can't you just take out the RNA from the cell and measure it? Can you do that from human cells? Can you take out the RNA from the human cells? No. So let me say something. Yeah. Anyone has done QRT PCR here? You have done. May I know your name, please? Enos? Evans. Can you spell it for me? Very nice. Evans. 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 Okay. So Evans, when you do QRT PCR, can you tell me how you do it? It is 3 o'clock. Why don't we pick it up? You guys discuss it because this is very interesting question. You will learn a lot about it because Venkatesh was saying, and then we'll pick up in QRT PCR. Okay? Because the thing is this, if it is RNA,
Pardon? Yeah, polyethylene. Yeah, yeah.
मॉनिटर करने के लिए कि बच्चे लोग
इसमें क्या होता है ना कि अगर आपका एटीट्यूड अच्छा है किसी भी चीज़ के प्रति तो आपको स्ट्रेस नहीं होगा। अगर स्ट्रेस नहीं होगा तो इम्यून सिस्टम बहुत स्ट्रांग रहेगा। अगर इम्यून सिस्टम बहुत स्ट्रांग है तो वो फाइट ऑफ कर देगा, है ना। तो प्लेसिबो इफेक्ट से क्या होता है कि लोग इतना स्ट्रांगली बिलीव करते हैं कि ठीक हो जाएगा, कि वो ठीक हो जाता है। जैसे अगर हम किसी के टच में आते हैं, मुझे पता है किसी को ये है, तो मुझे मालूम है कि अगर हम बहुत स्ट्रांगली कहेंगे तो वो मुझको बिलीव करेंगे क्योंकि हम इसमें काम करते हैं, है ना। तो हम कहेंगे हाँ ये तो मुझे मालूम है, ये तो ठीक हो ही जाता है, ये तो बहुत ही छोटी सी चीज़ है, ये तो अब तो ठीक होना ही है। तो मतलब वो पर्सन अगर बिलीव करता है अंदर से तो वो एक्चुअली ठीक हो जाता है और बहुत पॉजिटिव इफेक्ट आता है उसका। दिस इज़ अ नोन थिंग एक्चुअली। और अगर इसको बायोलॉजिकली समझ, हाँ, yeah, that's what I'm saying. If you have to explain it biologically, then what happens is that suppose you are stressed, right? So cortisol levels are very high. That just breaks down your immune system. If your immune system is breaking, the disease is going to spread, right? So if you keep your immune system healthy, like really healthy, तो वो कोई भी डिजीज होगा वो हट जाएगी। तो अगर वो पर्सन बहुत पॉजिटिव है तो उसका इम्यून सिस्टम बहुत स्ट्रांग रहेगा, है ना। दैट इज़ वन थिंग देयर। और जैसे अगर आप पॉजिटिव हैं तो और भी बहुत कुछ सिक्रीट होता रहता है जो कि हम लोग को बहुत हेल्प करता है ना। पर इम्यून सिस्टम का तो मतलब बहुत, आप खुद भी देखेंगे कि आप बहुत स्ट्रेस होते हैं तो आपके ऊपर कभी कोल्ड आ रहा है, कभी कुछ आ रहा है, कभी कुछ आ रहा है, तो यू बिकम वेरी वीक, है ना। तो ये तो सब चीज़ मतलब एवरीडे लाइफ में यू कैन सी, है ना। और बायोलॉजिकली इट इज़ प्रूवन, अगर आप स्ट्रेस है तो अल्जाइमर्स डिजीज़ हो जाएगी, है ना। और हैविंग सेड ऑल ऑफ दीज थिंग्स, फिर भी बीमारी आती ही है। जैसे कभी कभी कुछ नहीं होता, आप जो है बिल्कुल अच्छी खासी ज़िंदगी जी रहे हैं, बिल्कुल हेल्दी है, सब कुछ सही कर रहे हैं, आप कहीं घूमने गए, है ना, और आप बहुत अच्छे होटल में भी ठहरे, आप सब जगह से सब किया, पर आप घूम रहे हैं, कहाँ पे कौन सा वायरस आके किसने अटैक कर दिया, just you're going from one place to the other, or if the immune system is not able to clean it up, then many cancers are virus induced. अब आप उसको ऑन कर दीजिए, है ना। तो so placebo effect is real. No, it is not. No. If you do clinical trials, if you read clinical trials, a large percentage of patients do not receive the drug. A large percentage of people, they are deliberately given sugar pills, but they don't know they are getting sugar pills. They believe that they are getting the best medicine in the world, and they get well. And the strange thing is that those who are actually getting, some of them do not get well. And this thing has nothing to do with drug metabolism or anything like that. Pluripotency, no. Pluripotency is a feature of stem cells. Yeah. Cancer cells are not pluripotent. They are not. Oh, that is different. So they overexpress those proteins which make it mesenchymal, but they are not changing their lineage. They do change their lineage also, but they are not called pluripotent. Pluripotent definition means that they can change it to so for example, castration-resistant prostate cancer cells, if you give them androgen receptor therapy, they become neuroendocrine prostate cancer cell lines. So they have changed the lineage, but you would still not call them pluripotent cell lines. Pluripotent are those which can differentiate into many different cell types, and they will function as those cell types. Cancer cells are just adopting a new phenotype to survive. They're not serving anything, you know. They're not becoming endocrine cells and secreting something. They are just hiding in plain sight. They are not doing that. They are just trying to survive. Yeah, 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 yeah. It is, yeah, do all the damage. I've never seen that they are functioning for the body.
Is there any way that if this is the cancer, this is the microenvironment, but is there any way we can just shut it off? We isolate this section, even if it's in vivo, can we just
Seal it off.
remove all the access to the nutrients?
That's what you are doing with the angiogenesis inhibitors, right? That is exactly how it works. So all the nutrients are going through the bloods, right? Oxygen is going through the blood. So you are cutting down angiogenesis, and that is very effective. Okay, but then some cells survive even under low deprivation condition. They cannot survive without glucose. If so, see the tumor. So suppose this is the blood vessel. The tumor will not come here because here there is no glucose. Oxygen comes up to this place, glucose comes into this place. So they will stop here till they make new blood vessels. Then they will grow like this, right? So that is why they make blood vessels. So when you cut down the blood vessels, they shrink. They always shrink. But then what happens is that some cells survive under hypoxic condition. Of course, they're eating glucose. They don't have enough oxygen. But they become extremely resilient, and then you cannot kill them. The cells which survive under hypoxic conditions are extremely resilient, extremely resilient. You give right away. You give right away. The moment it is diagnosed, you give anti-angiogenesis. When it has metastasized, you absolutely have to give that, because once it has metastasized. So tomorrow I'm going to tell you about chemotherapy, surgery, and radiotherapy. We have talked about precision medicine. Now we'll step back and tell you the conventional ones. So when it has metastasized, you give chemotherapy absolutely, and angiogenesis inhibitor therapy, because now you cannot do surgery. You have to give systemic therapy. So you definitely give immunotherapy. For my friend, it was localized, right? Even then, he was given immunotherapy because immunotherapy is very effective. When I was preparing the lectures here, I came across a paper which said that immunotherapy works in 20% of the patients. I was surprised to see that because I have seen it working in huge number of patients. The only problem is resistance. So that is why I think, this is my thinking, that if one has to tackle cancer, it has to be very quick and before it develops resistance. No, few cancers can mutate very fast, right? Others are not that quick. But it is a very weird thing. Sometimes slowly growing cancers are more aggressive. The fast growing cancers are less aggressive. It's just there are many factors in play to determine which are aggressive. And like EGFR receptor, right? So HER2 is a EGFR family receptor. So EGFR receptor is upregulated in lung cancer, in breast cancer, and in many other cancer, right? So EGFR is very easy to target using small molecule because it's a kinase, it's a nice pocket. So they were given, so then it developed resistance. So then the second generation was given, it developed resistance. Now the third generation was given, it was highly effective, but then it developed resistance. So how does it develop resistance? So you inhibit EGFR, so EGFR is inhibited, so now they will upregulate another pathway, bypass. So EGFR is no longer needed, this other pathway takes over. So once you figure out again second pathway is taking over, then you combine it with this guy inhibitor also. So then it works for us time. In cancers, it is, I mean, in some cases, it is obviously, it goes away completely. In other cases, it is a playing game, how long you can prolong the life. Yeah. Say that again. Oh, you have to speak up. No, it is not.
Okay. We discussed about removing a lot of receptors from T cells before, to
So that it is not recognized as a foreign
foreign particles, yes. We were just inhibiting the host and the donor interaction in an aggressive way so that they don't counteract with each other. So then will it not affect the immune aspect of the T cell?
No. So it is the things which are removed, you keep the power of T cells intact. So what you do is that is something will come obviously next week because it is the final week. So these T cells, when you put these chimeric receptors, they are not alone. So I am going to show you a slide like first generation CAR, second generation CAR, third generation CAR, fourth generation CARs. So now I think 6-7 generation CARs are there. So you have these receptors, but along with these receptors also you have specific proteins co-expressed with them. So they bind, they get activated, some release cytokines, some they. So there is a whole army of things. This is a completely engineered thing, okay, based on how T cells react. So this whole generation of things have been added to that. And there is a lot of, people do a lot of fun stuff with CAR T, like they will make it so much fun, like different kinds of chimeric receptors, right, in one T cell. And also, so it is completely equipped, like you are sending a person in the war zone, completely equipped with all kinds of weapons. But you make sure that they don't, you are fighting for the host here, right? So the host cell doesn't attack you. So you have to be very friendly with the host cell and not attack the host cells and not get attacked by the host cells.
So are we giving immunosuppressors also?
No, we don't, because if you give immunosuppressor, you are shutting down the immune system, and then these test cells will be also shut down. You don't have to do that.
That means they're enabled with the power of killing.
Yeah, they have to be. Otherwise, CAR T cells are very, very effective in killing it. And then there are these NK cells, you know that. So they are CAR NK cells also. Yeah, those will also come there. So they have their own power and they have their own limitation. So people use CAR NK cells also. There is a CAR M cells also, the macrophage version of it. Yes, CAR M cells are there also. People are having a lot of fun doing, once a new technology comes, they're adding it to all different kinds of cell lines. So all of these things are in your lectures.
Predict the change what cancer might have in the next mutation?
So usually, so I'm going to show you a slide probably on Monday. So you can and you cannot, both things are true. So for example, when Gleevec was given, right, so there was a huge celebration at Novartis, and while we were still celebrating, right, when the first patient got it, the celebration was not even over. We had news that the patients have developed resistance, right? And I will show you a slide in which it shows at least 20-30 different mutations which occur due to Gleevec treatment. Okay, so yeah, we could not predict which mutations will occur. Okay, so there were so many mutations. So that is why there is new generation of Gleevec, like modification. There is one way you could possibly predict is that what you do, you take a cell line, right, which is basically, which has BCR-ABL in it, right? Keep in mind, this is a cell line. So you take as close of a cell line like CML, okay, with BCR-ABL in it. And you treat it with Gleevec at a very, very, very low dose, which is non-lethal dose. And you do it for 3 months, 4 months, 5 months. And then it will become resistant to Gleevec. And slowly, slowly you keep on increasing the dose till it is still remaining non-lethal. And if you sequence it, or if you do immunoblotting or anything, you will figure it out what proteins are upregulated. So that is a way in the lab that you can see what are the pathways which are upregulated. So you will get a pretty good idea before it shows up in patients. But keep in mind, human body is more complex than a cell line. So it is, yeah, so it is hard to predict what else. But also keep in mind that the PROTAC thing is there. So you can, there, people have made Gleevec PROTAC. So PROTAC is ubiquitination machinery on one end and your target in one end. So if you have to bring them together, so how will you bring kinase close to something? You have to target the kinase pocket, right? So on one end you will put Gleevec for BCR-ABL because that is going to bind BCR-ABL. Then you will put a linker, right, to give flexibility. And then you will put something which binds to the ubiquitination machinery. So you will make a bifunctional molecule, that's PROTAC. And you give it, and then it will bind both things, they will come together. And once they come together, they will get degraded. Right? So in that case, even if it has all these different mutators, you are just getting rid of the whole thing. But it should still bind to the pocket enough to get degraded. But if the mutation prevents it from binding it, then there is a problem. That is likely, but at least it will also give you some information, which may be helpful again. Tumors don't have a half-life because cells are dying, more cells are getting. It is always on the rise. Yeah, so balance is always towards more proliferation, less death. So people have done that. There are two things you can do. Some things will stop arrest cell growth. These are called cytostatic. And other compounds will kill the cells. These are called cytotoxic. So yeah, people do that all the time. The thing is that it is hard to, yeah. Go ahead.
Ma'am, we have discussed about biologics and biosimilar. So basically the biosimilars are mimicking the action of biologics only,
Yeah.
and they are the cheaper
Yeah.
alternates. So my question is that can we use biosimilar in place of biologics all the time? Means the efficacy will get hampered or not?
No, efficacy should not get hampered. If efficacy is hampered, it is not a biosimilar. Because if you're treating something, if it is like 2-3%, maybe the price is very cheap, then maybe somebody will go for a biosimilar. But if it is 20% less, nobody will use a biosimilar. So biosimilar is not a biosimilar if it is not similar in efficacy. That it is a cheap something. It is not worth anything. It has to have the same activity. So you can think of it as a generic drug versus the branded drug. They are identical. At least in chemistry, they are identical, right? But in biosimilar, it would be more or less identical with minor modifications. Suppose you know something works, right? But you also know if you attach this thing, it will become more stable. So those kind of modifications may be there. Maybe a cheaper version, cheaper way of making it. So because if you make a biosimilar which is not as efficacious, biosimilars are usually given for pretty serious diseases. Biologics are not given for fun, right? Because they are so expensive. So it has to work very efficiently, especially when someone is dealing with a disease like cancer which mutates. So you don't have every day counts. You cannot give cancer time to mutate. When you guys take antibiotics, right? So when you take antibiotics, the doctor gives you, is antibiotics, can you buy it in the stores these days? No, can you buy in the stores these days? I'm asking you. You cannot buy in the stores these days, right? You have to have doctor's prescription. In my time, it was freely available, right? So people used to buy. I have myself bought antibiotics, like tons of antibiotics. Every time you do want this, you take antibiotic. Because so then what happened, that we read it in a newspaper that a mother was giving antibiotic to her son who was 3 months old. So by the time he was 6 months old, he was resistant to antibiotic, and then he really had a bad attack of something, and antibiotics did not work, and he died, right? That was what opened up this thing that antibiotics cannot be given randomly, and that's how they became a prescription drug, right? So having said that, when you are given antibiotics, suppose you are given 30 tablets or capsules for 10 days, do you take the whole thing, or do you stop in between, or do you miss the dose? Even if the disease gets better. You know that, right? It is absolutely essential, because suppose I can miss some other drug, I cannot miss antibiotics, because what happens if you miss antibiotics, you give bacteria a chance to mutate. And if bacteria mutates, we are in serious trouble because it is resistant to that antibiotic. So while you're taking antibiotic, you cannot miss any dose. You cannot miss any dose. You cannot give bacteria a chance to mutate and attack you while. So you're taking antibiotics so quickly that they're dying. They just don't any time. Any one residual bacteria is also dead, right? That's the whole principle behind it. So you don't want to play with cancer and give it time. You don't want to miss anything.
Ma'am, after knocking out TCR in the CAR T cells, it cannot differentiate between self and non-self with the host cells. So how will it differentiate the cell? CAR T cell will differentiate between tumor cell and not self
Because
cells.
they are expressing these chimeric receptors, right? So the TCR, which would have attacked the host cells, is gone. So, but they have this chimeric antigen receptor, right? That is designed towards the host, that is designed towards the tumor cells. So they will only attack the tumor cells. Is that your question? Right? And it is not that simple either. So when I tell you about CAR T cells, so there are several generations of CAR T cells. So initially they just put the chimeric receptor there, but now they put a lot of other things there, like CD28 or CD something molecules. So in actual T cells, when the receptor is there, the CD28 or whatever it is next to the receptor. So when the regular TCR gets activated, it is bound to this one, and this secretes something. So they have mimicked the whole structure so that it functions like a real T cells, releases all the things. And what T cells do, they release this thing called granzyme or something, and perforin when they are activated. So when they lock horns with the tumor cells, they release that, and that goes and it creates hole in the tumor cells, and stuff gets in and kills the tumor cells.
according to all the like therapeutic strategies we have discussed, so among all which one is the higher, like which treatment has a higher chance of relapse, like according to all?
I don't know that thing. I don't know that thing because it totally depends on the cancer, kind of cancer, and what stage it was diagnosed, right? And so it is something totally dependent on the kind of cancer at the stage it was diagnosed, and then whether targeted therapy can be used. So it totally depends on the treatment plan also. So, and then it depends on the person's physiology, it depends on the person's microbiota, person's health otherwise, because to fight cancer you have to have healthy body. So for prostate cancer, right, prostate cancer is not that bad of a cancer, but when it occurs in real elderly people, you give chemotherapy, they have no strength to deal with chemotherapy, so it's fatal for them. Just chemotherapy is fatal. So it depends on many factors. But younger people usually recover faster, but then younger people also die because if it is aggressive. So, and people with all the money in the world cannot fight it if it is aggressive. Like really famous people with, super famous people got the cancer and they could not fight it off. So, it is a pretty bad disease. But the funny thing is that we didn't hear about this, I don't know, long time ago we never knew about this thing. I don't know whether we did not know about this thing or it didn't exist, because it seemed like it is a relatively recent disease. Part of it is that we are also eating a lot of processed food and things like that, which is also contributing to that. Initially we were using all raw food and raw things, so
historical way of eating, and we don't combine which is oil soluble and which is acidic. So we can't eat something tartaric with combination of milk or something. We can't.
yeah, I have heard of that. I don't know much about that. The way I eat is what I like to eat, kind of thing. Okay. So, like for example, I know you are not supposed to eat yogurt at night, right? But if I have to eat dahi bada, I have to eat dahi bada, right? So I know I should not eat yogurt at night. Like kheera, cucumber. There is a saying about cucumber. If you take in the morning, it is hira. Kheera is hira in the morning. Like if you take it in breakfast, in lunch it is not as good, and it is almost zahar in the evening. But if I have to take kheera, I will take whenever I feel like taking kheera. So I don't follow these rules, but I'm 100% sure these rules are really important, because Ayurvedic is extremely important and nothing is wrong there probably. So I would respect Ayurveda over my own knowledge about food. But whatever they say is correct. Oh, there is no doubt about it. There is no doubt about it. And one thing I can share, this is my own experience. So, it happened to me in India also, it happened to me in US also. So I was in Gyan course last time, right? So after the Gyan course, and I'm going to the same restaurant again this year also. So we went to Sayaji or something, right? So that was the last day, and it was 24th December that time, because I left on 25th December that in that Gyan course. So 24th night, I went to Sayaji along with the whole group of people, and I ate food there, and I was so sick on 25th. my flight, I mean, it was horrible flight for me because it was just as bad as it gets. I somehow landed to Chicago, and there was no way I could. My home is 3 hours away from Chicago, and I was in no way to go there. It was just a long story. And the why I had that reaction, the food was very tasty, and then I realized that they had added preservative because they had about 100 different variety there. Honestly, no joke. So if you make these many food, you cannot throw it away. So they are preservatives. So they freeze, they thaw, they freeze, they thaw, they freeze, they thaw. And I, whatever my PGX is, I cannot deal with preservatives. So that had a strong reaction, right? It took me some time to understand what, because I didn't eat much and I was so sick. So this happened in India, and this happened exactly to me in US also. So again, I went to an Indian restaurant there, and they make food like buffet, day in and day out, evening, lunch, dinner, lunch, dinner, lunch, dinner, and I ate there. And I had taken a speaker. That day was Shivratri, and I had taken a speaker for dinner. And we were eating, and I got so sick that I had to lie down on floor. Like, I thought I will lose consciousness. So my husband came, and he took the speaker and dropped him to the hotel and took me to the hospital. And again, it was the preservative thing there also. Like, while eating the food, I had such a strong reaction. So I know it is preservatives. And there is yet another story about the same restaurant. So when these people, they buy processed food in tins, you can imagine how much preservative is in tin food, because it is at room temperature, right? So that is actually poisonous to eat that kind of food. So, and then people drink soda, and they drink and they drink and they drink. Like, we are taking this kind of tea with so much sugar. Tea is not bad. This much sugar is really bad. Like, maybe not for you guys, because you guys are going up and down all day long and you're burning it off. But in general, it is pretty bad to have this much sugar. So everything contributes. My grandfather never got anything like that, because the lifestyle was different that time, right? None of my ancestors, nobody had ever heard of cancer. So it is just the lifestyle. Then pollution is playing its own part here also. You haven't done anything wrong. Like, you are just living, we are just living in those conditions. And also, when you watch cooking channels or something, I'm just surprised, like, processing. You boil aloo, then you make pakoda out of it, then you slice it up again, and then you make puri out of it, and then you take the puri, and then you put it in a mixer and make a powder of it, and then you add the powder to that. I mean, after a while, I thought, how much more process? I'm not joking. I can tell you the website also. So even just because they have to make money, so they have to put a new recipe every single day, so that they can keep getting enough traffic. So they are just taking the same thing and processing and processing and processing and processing. You cannot do that. When you cook food, you have to cook food so that the nutrients are preserved there. You guys are too young, but when pressure cooker came, that was the biggest selling point, that it preserves the nutrients because it is so quick. Otherwise, without pressure cooker, you're cooking forever, right? And that kills the whole thing. So when you make any sabzi, like dry sabzi, you don't add water and burn it. You don't add water. You let the water in the sabzi to cook by itself by keeping it low flame, so that you preserve the nutrients, right? So what I'm trying to say is that our lifestyle has created these diseases. It wasn't there before, at least I have not heard of. But also there is another flip side to it, right? Earlier, when I was young, in India, the average life was 61, 62. If people reach 60, people barely lived beyond 60. There were always some exceptions. Then the median age increased and increased and increased, right? In US, it is, I don't know, 85, 90, something like that, which is higher than here. So if the age is increasing, so are the diseases. If you are living up to 60, you're not likely to get many diseases. But then why would you die at 60 if there was nothing wrong? Right? There was something wrong. That's why people were also dying young, because there were not enough medicines. Right? So this age-related disease like Alzheimer's are coming because people are living that long. But then not everyone gets Alzheimer either. So let's not worry too much about the diseases. You live happily, you live a nice life, leave the rest to whatever it is. You do the right thing, never think. Because, even if you do all the right things in life, sometimes stress comes out of nowhere, and sometimes stress disappears out of nowhere also, right? Good days come, bad days come. Just take life easily, take it lightly, do the best, and don't worry too much. And I'm telling you very seriously, it's not a thing. Don't eat out unnecessarily. If you can cook, cook at home. Like, I know you guys cannot do that, but I'm just saying that. Don't drink alcohol, because that is really bad. Do exercise whenever you can, and keep your stress levels under control. And always do something that you love. No matter how hard you work, you have to have your own fun thing going, because you have to rest when we are kids, right, we are told to study all the time, right? Just you have to do this and that. But once you are a professional, you also, when you are already disciplined enough to come to this stage at this institute here, right? If you were not disciplined, you would not be here, right? So you know how to manage your time and everything. So once you have that culture already, then you have to also find time to relax yourself in whichever way you feel relaxed. If you like reading, if you like watching something, if you like whatever you like, whichever way. So just find time to relax. Life is a lot of fun. Don't worry about it. You don't have to worry about these diseases so much. Thankfully, our diets are very good here, so that will protect us. And I will also tell you a trick, a real good trick if you don't know already. So when you cook your food, always add, if it has turmeric powder, always add kali mirch to it, black pepper. Your turmeric absorption will increase to 2000 times. Okay, 2000 times. That is a miraculous thing which will happen. So the cancer chances are almost negligible after that. So this is something you can always keep kali mirch with you, and even when you're eating in mess, you can just add. Kali mirch will only add good taste to it, right? And your turmeric absorption will just go 2000 times. You can go to the web and check, it is 2000 times. So that is extremely helpful, because it will reduce inflammation in your body if there is any inflammation. It will turn off all the signaling pathways, NF-kappa B pathway, which lead to all these diseases. It is antioxidant. So all the things cancer hates, that's what it does. When you cook food at home, you guys are cooking. When you make the dough, add haldi to the dough, so that you are also consuming haldi that way. No, but you can always take it that way also. Yeah, the more haldi you take, and if you add kali mirch to your food in the body, whether you ate it with curry or it doesn't matter, as long as it is going in the body along with haldi, that's all it is. Body will never become resistant to curcumin, never ever. It's such a good thing. It will never become resistant to it. Yeah, Curcumin is a miraculous thing. A lot of Indians who go to US, they spend their life working on curcumin. They spend their life working on tulsi. Yeah, all their life. Like every single paper has tulsi in it. All single paper has curcumin in it. These red grapes, they are very good, right? Red grapes, not the green ones. So funding agencies gave a lot of money, like why red grapes are so good. The simple principle is that they have polyphenols and they are antioxidants, right? The more colorful the vegetable is, the healthier it is. Green color, red color, brown. I mean brown, unless it is not rotten. Like good colors, bright colors, good. Tomato, lycopene, right? Carrots, all good. So blueberries are superfood. Blueberries are called superfood. Do you get blueberries now here? You don't get it, right? Yeah. I know of a person who eats blueberries and he was telling me he gets frozen blueberries. Yeah, because it's not easy to get. And I'm guessing it is pretty expensive also. Yeah. Oh, yeah, absolutely. Absolutely. 100%. Yeah, yeah, yeah. Teflon covering. I don't know that. I don't know that. If Teflon is harmful, then it is really bad. You are talking about non-stick coating? I had no idea. I would never use it if I know it, but I also use it. Yeah. So Teflon is that bad? Oh my God. I'm just thinking of all my utensils which have Teflon in it and I'm not going to use it. I also have a lot of steel things, so I'm going to switch to steel things now. Yeah, thank you for telling me that. Yeah. Aluminium, like long time ago, we used to use aluminium utensils, right? It was very common in old days, not recently, like even before my time, right? And aluminium, if it leach, so especially this idli thing used to be, instead of steel, it used to be made of aluminium at that time. So aluminium, if it leaches even a little bit, it gives Alzheimer's disease. Okay, the brain degenerates. So it is really bad. Iron, we have tons of iron in our body, right? As you know, and iron is very tightly kept in check all the time, very properly kept in check. But iron in the wrong form is extremely dangerous. If it floats around freely, the ferrous and the ferric, it will be very bad. Okay, I just taught a bioinorganic course to the students, which is not even my field, but I had real fun because I learned a lot of stuff. So the metals can be really, really bad for us. Also, unless in the good form, and there is some metals which should not go in our body, like copper. We need copper for survival because there are so many enzymes which are copper dependent enzyme, like copper, zinc, sod, and all those things. But like rust is bad and iron cannot be in the free form. So yeah, and metals can be very bad for you. And there are some metals, like, it is just really bad. It should not be in our body. So lead poisoning, right? Yeah. Cosmetics have contamination with metals. So there is always this, don't use Revlon, this and that, because it has this many parts. PP, yeah, parts per million contamination of this thing. The bottom line is that not to stress about the disease also is to keep away the disease. Not think about the disease all the time. Just keep it away. It's not going to come to you. If we start stressing about the disease, we are inviting the disease, right? Yeah, yeah. So don't stress about the disease. Vertigo. Thyroid is a very common disease. Like in US, I have seen every second person has thyroid thing, and I don't know. So the place where I live at Purdue, right? So when I moved there, so I bought a house, and they said, "Oh, you should put the water purifier here because the water is not pure." And I thought they are just trying to make money, and I didn't pay attention. But apparently the water isn't very good. And then I got the thyroid problem. And then I changed the water. So I buy water now. I don't drink the water which comes in the tap. So then I mean, I still take medicine, but it hasn't gone worse than before. They have the RO system, but RO system is more complicated to install. It is much easier because you have to keep changing the filter every few. But it is much better to get the water delivered at home. So you don't have to do anything. They just deliver water bottles at your home. So that is easier for us. So because we investigated the RA system, so it was just to like take care of the filter and everything. So getting the water was much easier option for us. So thyroid is a pretty common problem, but it is also a very manageable disease. One thing you guys have to be cautious of, all of you, is diabetes, because diabetes is a silent killer. It's worse than cancer. So you have to really take care of diabetes, and diabetes sneaks in out of nowhere. Like just eating a little bit more sugar than usual can cause diabetes. And long-term use of these tea can cause diabetes. I'm not joking, I'm just very serious about it. That much sugar is very dangerous. So these days I'm more concerned about these metabolic diseases because they are in this lifestyle, obesity is increasing. Even in our country, people used to be a lot thinner before than they are now, because there were not so many cars and people were biking, and the lives, and it will keep on changing. There's nothing good or bad about it. This is what life is. It keeps on changing all the time, right? So initially nobody went to gym because everybody was walking, and it was a natural part of life. When we used to go to school, if it was in walking distance, we would walk. We would not, take a car to go there. It was just a common culture those days. So no, there are some special kind of virus like HPV and this kind of viruses which cause liver cancer. So not all cancers are caused by viruses, but liver cancer is one of the cancer which is caused by virus, and they are special virus. These are not just random virus which can cause cancer. So yeah, so that's what I'm saying, that a person is walking and just got exposed to something. Evans, go ahead. Yeah. Yes, you introduce mRNA vaccine to the
Okay.
body.
Yeah. So the sales machinery will be using it to make the proteins.
Yes.
we make the proteins or the antibodies that we use to fight the cancer or any other disease.
Yeah.
So, and the memory will be retained in the body.
Yes.
So my question is that how is the cell retaining the memory, or how is the body retaining the memory? Yet it is starting midway. It is not starting from the DNA. It is starting from mRNA midway. So how is it able to remember? It is not starting from the scratch, the synthesis.
No, it has nothing to do with DNA or RNA there. So the way it works is this, that whether it is DNA or RNA, right? Suppose you even introduce the protein there directly, forget about the RNA, right? So if you put the protein in there, let's say for mRNA vaccine, you put mRNA there, right? So this mRNA for COVID vaccine was made against the spike protein of COVID virus, right? So they took the mRNA, they took a sequence specific to the spike, they made the RNA, they delivered it using nanoparticles or whatever they used, right? Now that mRNA will make that part of the spike protein, correct? Then what will happen is that the spike protein will be displayed as a foreign particle. So B cells will come and look at that. Okay, and the B cells will recognize, so these MSC molecules, they will present this, look at this is the foreign particle. So it is not shown as a whole spike. Spike is further made into pieces and displayed like this, right? So this is actually displayed like this. Now B cells will come and they have to bind these particles, right? So B cells will now undergo, what is that process called, like random mutagenesis in their specific regions, and they will make recombination and all of these things, and they will make trillions and trillions and trillions of combinations, and out of those trillions of combination, every guy will come and bind and see which one can bind. So 98% will die because they cannot bind, but 1 or 2% will bind those very efficiently. Those will be the survivors, and then those survivors will further tune themselves to make it even better survivors. So anything which is less will be dead. So now after like 2-3 rounds or many rounds of this, you will get B cells which bind them extremely. So they are the one which are producing antibodies, right? So those antibodies, those B cells which are producing those antibodies, which are the best binders, so they will clean up the mess, and then they will, if there is no more attack there, they will retain those B cells till we live in our body, and they are called memory B cells. So anytime in the future, if a similar spike protein comes, those B cells don't have to undergo the recombination process to look for it. It's a delayed response, but it takes time. That also I'm going to tell you about the innate response versus the acquired response. So it takes few days to launch up that attack. That is why when we get vaccine, we often get fever, because the body's triggering an immune response against that vaccine. So that is when B cells are recombining in, and those memory cells are always stored in our body till the last day of our life. So that is why we are always equipped. The moment we see that in a day, the whole body is full of antibodies to clean it up. So it is retained. So you are talking about mRNA here. We don't even have to think. If we put in the protein piece, which is after there, it's going to be the same thing. If you put the mRNA in the body, it will take an hour to get the protein made. So it is, so initially before COVID, nobody thought about mRNA because they thought mRNA is going to get degraded. Nobody has ever done that. And there was a lady in UPenn, University of Pennsylvania. So she used to work on mRNA something, and nobody cared about that. They thought that she's doing a useless work. So she was thrown out, like she had a nice lab, so they took away the lab space, gave her a poor office, a poor lab. Nobody was ready to collaborate with her. Like she was given a real corner. Nobody would talk to her, nothing. And then when COVID happened, her method worked, and she got the Nobel Prize. And that's when she told how she was treated by the university. So just imagine somebody really shoved down and that person gets the Nobel Prize because she was working on the mRNA part of it, which people thought was not worth working on. So science is, so even if you come up with any idea which seems pretty weird, if it seems weird to me, that is my limitation, that I'm not seeing beyond that. It is not that your idea is bad. You have to think really out of the box. And if you think out of the box, you may not know exactly how to do it, but if you think out of the box, you will find a way to do it, right? Any other questions, guys? So you guys are going to relax finally tomorrow, right? After 4 intense days. Go ahead. Huh?
Have some time to entertain questions.
Oh, absolutely. I told, because I have to tell the driver to come in advance. Otherwise, I'm sitting here, he doesn't show up. So I told him to come at 4:15. So we have plenty of time.
Actually, I just wanted to know about drug tolerant persisters.
About what?
Drug tolerant persister cells.
Drug what?
Drug tolerant persister cells, DTPs.
Oh, drug tolerant persistences. Yeah.
Yeah, so I just wanted to know what is the highest potential research that is going on in these cells, particularly maybe in triple negative breast cancer. It is most common, the drug tolerant persister cells.
So I don't know much about drug tolerant persistent cells, but what I know about triple negative, why it is so aggressive. So there are
Lack the
3
receptors.
receptors, right?
Yeah.
So if the receptors are expressing, you can do targeted therapy. If the receptors are not expressing, what do you target there?
Yeah,
So
exactly.
you go for chemotherapy because you just don't know what else to target, and that chemotherapy is too toxic. So a person with HER2 positive cancer was treated with chemotherapy because the person did not spend time to figure out what kind of cancer it is, and the person died. And HER2 is totally treatable with the right therapy. So that makes the triple negative cells very aggressive. So I don't know if it is the role of these persistent cells to make it aggressive. I don't know, but cancer cells keep on mutating. Just imagine if they have HER2 receptor and you target HER2 receptor, they will make HER2 disappear.
Yeah,
Now they will
exactly.
depend on MET amplification.
Right.
So that is always going on. Yeah. I wish I could say this is the magic bullet, but the last lecture of this Gyan course is polypharmacology. It was 10-20 years ago, my advisor coined the word magic bullet, that you have to make the magic bullet, it goes and hits the right target. Now they have realized magic bullet doesn't work. They said magic shotgun now, that you kill all the right targets at the same time, because people have realized killing one target is not going to kill cancer cells. So you just have the magic that you kill all the right people at the same time, so that they cannot bypass this to this to this to this. And that is why your question is very relevant, that figure out the resistance beforehand so that you are prepared. And these days it is very common to take biopsy from patients and you make a cell line out of that. And it is very easy to do that. So in our lab, we have many patient-derived cell lines. So these are not the common cell lines. So they are better than, the general cell lines. And you can do a lot of studies there. And all these genomic, you can do single cell RNA-seq, right? You can do proteomics. You can do spatial proteomics. So you can do tons of things which will give you an idea. And these days the companies can analyze the data for you. So even if you are not so expert on it, they can help you analyze the data. And you don't have to have all the expertise in your own lab, because you send it, they will do it. So even if you have 100 different expertise in your lab, you can go and get the other things done by the companies. So that will give you quite a bit of idea of what is going on. So it's a really good idea to predict the resistance beforehand, so that you are always prepared with the next and the next and the next. All right, guys, let's wrap it for today, and then I'll see you guys on Monday.